piecework. It's not going to happen.
Turn it on. Okay, morning everyone. Great to see you. It's really disconcerting that, but never mind. So welcome everyone to our board meeting, our board of directors meeting held in public. It's really lovely to see some of our council of governors here. You're very welcome, and also members of the public and some of our staff as well. Really delightful. I've got confirmed apologies from Melinda Bird and Julian Foster. Are there any others?
There's also apologies from Faisal Sethi, and Gary O'Hare will join a bit later.
Lovely, thanks very much indeed for that, Adi. The board's being live streamed, and that's in order to increase transparency. And I'm hoping that that's still being live streamed because something different's come up on the screen. Rebecca, could you just work out whether we're still being live streamed?
Yes, it is. I'm just to let you know that there are remote attendees.
Oh, lovely. That's fantastic. Thanks very much indeed. Great, thank you. And it's lovely to see that there are people who are joining us live stream, and you're also very welcome as well. So just a reminder to ourselves, this is a meeting of the NSFT board that takes place in public, but it's not a public meeting, and there is time for question at the end of the meeting from members of the public, Council of Governors, but I'm not going to be taking any contributions until the end of the meeting, if that's okay with everyone. This is a really important board meeting. We don't judge the substance of our board meeting by the number of pages of the pay pack, but there are a lot this time around And while everything on the agenda is really important, what I describe as the big ticket items are really key today. So we're going to be talking about improving crisis and 111 services. We're going to be reflecting on learning from deaths. We're 1 year on, we've got our annual report. We're going to be addressing how we properly involve carers in all aspects of care, and we've got a really excellent report on how we take our work on race equity forward. So those are the really big ticket items. Of course, the most important thing in our board agenda from all of our perspectives is our service user experience. It's lovely to welcome Stephen, who's going to be talking in a little bit. But before we go into the agenda, I'd just like to take a moment to recognise and thank Tricia Fuller, who is very sadly stepping down from the Trust at the end of September. I have done my absolute utmost and failed miserably to persuade her to stay longer, but she's stepping down as a non-executive director as her tenure comes to an end. Tricia's been with NSFT for 6 years, and it's no exaggeration, I think, to say that we're going to be losing an institution. Your tenure has been nothing short of remarkable, Tricia, and as chair of the People and Culture Committee, you've been fearless and relentless in challenging the Trust to get better and to get the basics right. And your influence is really clear, I think, in the agenda today, when we see the strong focus that you've had on supervisions, PDRs, mandatory training, retention, reduction in staff turnover. These are all areas where you've absolutely been laser-like in your focus, and these are all areas where we are beginning to do better, I think, in an embedded way. So that unwavering focus has really enabled us to move forwards and at the same time create that kind of culture, that more supportive culture that we've always striven for. And to say that Tricia worked tirelessly is an understatement. Well, her formal time, we all know this as non-executive directors. We sign up to doing 4 days a month if you're a non-executive director, but there's been periods when you've worked literally 7 days a week for the Trust in order to make sure we keep the wheels on and we get things much more stable, and that's really paying dividends. I think you'll also see the results of your work, Tricia, through the work you've done in chairing the consultants panel, which is where we recruit consultants, because there's some incredible statistics now about the reduction in vacancies and turnover, both of doctors and nurses, in terms of recruitment. And as my deputy chair, Tricia, if I could just say something personal, you've really offered me wise counsel, unstinting support, and so it's really hard for me to put into words today how much Tricia's going to be missed. But your legacy will be visible all around us, not just in the strength of this fantastic board, which you play such a fundamental part in recruiting, but also in creating that healthy workplace culture that we're striving for. So thank you very much, Tricia, indeed. We've got a full agenda today. I'm going to take the reports, if I may, as read when you go into your introductions. And of course, there is going to be a short comfort break midway through the meeting, and I've not been notified of any urgent business. Okay, can we move on to declarations of interest? Are they as reported, and can we approve the declarations? Okay, we've now got the minutes of the public meeting that was held on the 5th of June. We have the public minutes in our agenda pack. Could I check that there are any corrections? Are we happy to approve the minutes as accurate? Yeah, lovely, great, thanks very much. And we've also got the action log, which is looking distinctly improved. Thank you very much indeed for everyone that's done work on that in terms of the completed items. Are there any issues in terms of the action log that anyone would like to raise, or any matters arising from the minutes that aren't otherwise on the agenda? So, that's good. I'm liking that. Thank you, that's lovely. That was a pleasurable moment of the board meeting. So could we, we've taken the minutes as approved, and we'll move on to the next item of the agenda, which is what I always describe as the most important moment of reflection. I'm delighted that Stephen's here with us, as I said, and I'm going to hand over to Kath to conduct us through the service user and carer experience.
Thank you so much. Oh gosh, that's a bit loud. Firstly, I just wanted to say, as with all of the service user and carer experience items that we have on our meetings in public, just to share that there may be elements of the videos that people might find triggering, and I think it's fair to say if people feel the need to either step out or switch off for that item, then just encouraging that's absolutely fine for people to do. However, I'd just like to say a huge thanks not only to Stephen, who's sitting here on my right, but also other contributors. So Nina and Lucy have both contributed to this video, and they've been supported by Sue Wilgoss, who's our advisor for suicide prevention with lived experience. And I just want to say before we start the video how important it is that we continue to hear the real experiences of people who use our services, because that's how we learn and improve. So thank you very much, and maybe we'll just step into the video.
Trigger warning. This video contains conversations on the subject of self-harm and suicide.
Stephen has had 2 experiences of the 111 mental health option in the same week. These experiences highlighted inconsistencies in response time. Call 1, Sunday.
Well, Sunday night I was in crisis and wanted to end my life. So I phoned 111 option 2, and they kept me waiting, ringing, 45 minutes plus. So I hung up and I felt rejected. I felt disappointed. No one could help me. I mean, when 111 option 1 and 2 first started, they answered promptly. But Sunday just gone, just kept ringing again, and I had a washing machine head, stuck in constant final spin. I was drying out. Felt so let down.
Call 2, Tuesday.
I wanted to end my life, and I dialed 111 option 2, and they actually answered within 2 minutes. And the lady suggested I phone for an ambulance. That's another thing. When I phoned for an ambulance, they said a 3-hour wait. And that was a priority, even though I wanted to end my life. I had a knife in front of me and everything.
When you've got through, what has your experience of the 111 mental health option been like?
Cool, calm and collective. Sometimes in parts I was in tears. Couldn't stop shaking. But they're very good. The staff they do have are very good on the phone. You can get go through triage, and you can get a call back from next one up, and then the doctor call back.
What puts you off calling the 111 mental health option?
The reason I didn't speak to 111 was because whenever you phone 111, they tell you to go to the hospital. I needed someone to speak to, someone to help me. To go to A&E isn't a nice place because they don't understand me. They want, places completely overwhelm them from the minute you walk in. Being autistic as well, I haven't had good experiences. And so I just couldn't bring myself to, because in a way I still sort of knew that wouldn't be the right thing. And so that's what phoning 111 for me, that's what that always means. That means that they're going to tell you to go to A&E, because that's what they always do. Whereas going to Wellbeing or Mind is a better place. Going to somewhere familiar, somewhere that they're friendlier and gives me a bit of warmth. I don't get a friendly feeling from going to 111. It always feels like you're always waiting, you're an inconvenience.
What improvements do you think could be made?
I think that I think a sort of a warmer. Everything comes across as quite like corporate, quite NHSy, like quite corporate. It doesn't come across as welcoming as other organisations.
I just had an idea actually. 111 option 1 and 2. There could also be a video link, so people on the phone actually get to see you and see what emotions are going through and what's around you. That's an idea.
One user has chosen to remain anonymous.
Thank you for that, Stephen, and the other users involved in that really profoundly moving film. I'm going to hand back to Kath. And I'd obviously invite you if you want to say, but through Kath.
Yeah, thank you so much. So from my perspective, again, reiterating a huge thank you to everybody that contributed, but particularly Stephen coming today. That's been really helpful, and hopefully you're feeling welcomed, that actually we want to hear your story and your experience and use that to learn. So for me, there were 3 big themes there, but that's not necessarily all that we heard, but it was about the variation in access, the pathway where our service users that contributed felt that they were being sent to A&E or phoning an ambulance, which isn't necessarily an effective or compassionate approach to providing care when people need help. But there was also some suggestions about the interface for people with regard to our website needs to be less corporate and more welcoming. And also, Stephen, you came up with a great suggestion about opportunities to enhance the digital interface when people are calling 111 option 2, because actually many people would prefer to see someone rather than just hearing. So for me, they are the things that I think warrant a discussion today. So I'll hand back to Zoe. Thank you.
Lovely. Thanks very much, Kath. Stephen, I'd like to ask, was that the right summing up, and is there anything else that you'd like to add?
That's everything that sums up, to be honest. It was not a good experience the first time around. The video link could be a brilliant idea, because then the people at 111 option 2 be able to see the person, what they're doing at the time, what the emotions actually going through. Voice is okay, but the image is more profound, is where I see it. Thank you.
Well, personally, I couldn't agree more, Stephen, but let's see what other members of the board would like to respond and say. I've got Rebecca, then Jason.
Thank you, Chair, and thank you, Stephen, for sharing that very personal story this morning, which I'm sure we'll all reflect on long after this morning's meeting, and also for the other patient who shared their story. I think you rightly touch on the real importance of the warm, welcoming nature of our services, whether you're talking to somebody or whether you're accessing through the website. So I'd just like to make an offer to reach out to you, and we will through other patients as well, as we begin to relook at our website to make it less corporate and more accessible for everybody. Thank you again, and if I can help in any way as well around, I think some of the customer care training, and it's a word we don't use in the NHS, the word customer, but just teaching our staff how to be warm and welcoming, particularly on a phone line. I think it's something we need to think again about. So thank you for sharing that with us, and I look forward to working with you further on our website. Thank you, Chair.
That's the trouble with coming here, Stephen. You get roped into doing even more things. So I'm not sure when we met the other day I warned you properly that might be the outcome of this. But Rebecca's in charge of everything to do with the way that the trust kind of speaks to the public, so communications. So she's in charge of all of that. So she's the right person to talk to on that. I'd like to call Jason next. And Jason's in charge of finance, Stephen. So he's the man that's in charge of all the money.
Thank you, Stephen, for coming today, and thank you for sharing your experience. I think what came across clearly in the videos was that there's a disconnect between an individual's needs and the service provision we're giving. It doesn't feel personalised enough, and it shouldn't just be a signposting call. And I think from what we heard is that sometimes that is the case, and it just feels like people are being signposted somewhere else, and we need to reflect on that and see how we can really enhance the service to make sure that isn't the case. And the video call idea, I think, is a fantastic idea. We need to really modernise the way we provide our services. So I absolutely get involved in trying to take that forward. So thank you.
Well said, Jason. Thank you very much for that. Andy Mack.
Thanks. Stephen, first of all, thank you so much for sharing that. The point I just wanted to pick up on is really there's commonality around the theme of being pushed or diverted towards ED in all of the stories. And I think there's some real work we need to do around that whole pathway. I've had some fortunate to visit some other areas recently where there's some of the mental health ED options are appearing across the country. I wouldn't want any of my family signposted to an ED when they've got a mental health presentation or an issue. It's not the right place to go. But I think even with all of the work coming downstream in terms of what we might be able to deliver, I think there's stuff we can do now. So we do have options around our crisis hubs in our pathways. We have our crisis team bases, and some of this for me is around the culture and how we work harder to provide a much less restrictive environment, a safer space for people to go to. So if you were to ring 111 in the future, I hope we could get to a point where we could ask or suggest alternatives. That it would be signposting, Jason, but to a point, to the right place. So coming into perhaps the crisis team base or an alternative crisis hub in the local area. So I just wanted to sort of recognise that and say there is stuff we can do now that we're focusing in on about how we optimise the potential to give you a different place to ED now. But yeah, thank you.
Thanks, Andy. That was a really important point, which will come up again later on in the agenda. Tricia.
Thanks, Stephen, and thanks for your courage and bravery coming here today. I don't want to repeat anything everybody else has said as well, but it's very courageous of you to come, and I'm really delighted to see you here today. And I hope you're feeling marginally better than you were. I think the whole issue, on a personal level with a family member, I have had experience of 111, and I share your misgivings about it, and they've been long-standing. And we do seem to have a determination now to resolve those. And I suppose I was wondering, asking the question, whether one day you rang was a Sunday and one was a Tuesday, whether we know what our statistics are, whether the service is less good over the weekend or it's our staffing less good. So I think that's just a question to ask. Do we know the answer to that? But really pleased to see you, Stephen, and you're a very courageous man, so thank you.
Thank you. I do have one thing to say. We don't actually have a crisis line in Lowestoft. You have to phone like Norwich or Ipswich or Great Yarmouth. May I suggest be grateful, everyone would be grateful to have a crisis line in Lowestoft we could ring to be someone close to home sort of thing. Thank you.
Andy, do you want to come back on that?
So I guess if we can have a look at what the local offer is, I'd be really happy to meet up actually outside of here and have a think about what locally is available across Great Yarmouth and Waveney. We've got obviously the 111 which you've spoken about, which caters for the whole of Norfolk and Suffolk, but clearly from what you've said, that didn't suit the needs of the time. So really happy to have a look at what we could do more locally with the outside of here.
Thanks very much for that, Andy. Thanks for that contribution. I'm going to come to you in a sec, Kath. I've got you. I'm going to go to Anthony next.
Thank you, Chair. Hi, Stephen. I'm Anthony Deary. I'm the Chief Nurse at the Trust, and like other colleagues, thank you very much for what you've shared today, and I support all of the comments that have been made. I know from meetings that I have with people who use the 111 service in crisis just how desperate you're feeling at that point when you have to pick up the phone. So I was really sorry to hear about the quality of the experience that you've had. And certainly I would want to use your experience and that of the colleague who was anonymous to support the learning, the teaching and the development of the service and the team. So I'll certainly be taking it forward from a quality point of view. Thank you.
Yeah, really well said, Anthony, and it was right that you heard from Anthony an apology, Stephen, for that service that you received from us as well. So thanks for saying that, Anthony. Stuart?
Thanks, Zoe. Thanks, Stephen. Thanks for sharing your story. It's really, really helpful and really learning from us, being able to use sort of your experience, albeit it wasn't a good experience that you had. We're doing lots and lots of work. Tricia, you pick up the point about data. We are really trying to understand our business in 111. Some of the issues that we've had historically is capacity and demand and not really understanding that the way we should have. We didn't have the right number of staff answering the calls at the right time, hence you're having to wait what is it, unacceptable length of time for your call to be answered. So we've looked at that and it's making sure we've got the right person with the right skills on the other end of that call as well, to be able to offer you the help and offer you the advice that you need, and also the right number of options are available to us as well for to get somebody out to see you if that's the required response. There are times when we do have to send people to AD and that's the right thing to do. But, you know, ideally we'll get somebody out to see you as well on the back of that. So lots of work underway, lots of work to try and improve what we've currently got. Would love to get you involved in some of that. The idea that you brought up around the video, something we definitely need to look at. Thanks very much for your time.
I'd just like to say one last thing. It's actually thanks to Sue, who lived loud for Danny. I wouldn't be here today making my point, putting my point across. It's actually thanks to Sue and lived loud for Danny. And everyone's welcome to come to the group to see what gets put into
Come see all the guys.
Come see us, yeah, come see all the guys. Thank you.
Yeah, it's a really important point, Stephen. The work that Sue does is extraordinary and life-saving. Thank you, Sue. Linz.
Thank you, Chair. And thank you, Stephen. Your story is really powerful. So your strength and bravery in coming here today is outstanding. Thank you. You're doing really well. Doing really well. I wanted to ask my colleagues around the room. So we had a first response car. What's happening with the first response car now? And would that have supported Stephen or anyone else using 111?
Thanks very much, Andy.
Yeah, thanks. So I think you're referring to like the joint response car between ambulance and the trust. That's still in place. And the way that works, and this is something we're looking at, actually, is it's through the ambulance. So if we call an ambulance, it can be diverted to somebody with a mental health crisis. Obviously, it's dependent on when that's available. Sorry, away from the microphone. That's obviously dependent on when it's available and whether it's being allocated to another call. So we've recently increased the amount of time that's available, but it's something, when I talked about the wider pathway, we need to keep examining about whether we can expand the resources that mean that we can do something alternative to going into hospital, but that potentially could have been a resource that could be used in that circumstance.
Thanks very much, Andy. That's really helpful. Kath.
Thank you. A few points that I was going to raise have already been mentioned. I think it's really interesting to hear about the lack of a crisis cafe, crisis house in Lowestoft. And I think it's a real good opportunity for us in the progression into neighbourhood health hubs and neighbourhood health centres that have been announced as part of the 10-year health plan, and working with our system partners in identifying need through the use of population health data, which is data we can access even from all parts of the system to understand the needs of the population. So I think it's quite exciting times ahead, and we're really pushing and working with the system for Great Yarmouth and Waveney, in which Lowestoft is within Waveney, to be well represented as part of one of the early adopter hubs. So I think that's really exciting for us. Just making reference explicitly to the fact that we will be hearing later on the agenda from Stuart about the progress update with the 111 and crisis transformation programme, so there'll be an opportunity for us to reflect on what we've heard now and maybe feed that into to the discussion that we have during that item. And also to say that Sue is here today representing the Norfolk and Wales, the Central Norfolk system that provides and leads on the 111. There is still a huge amount to do. I think you mentioned, Stuart, about looking at the demand, and when we need staff, we have adjusted our skill mix within the service, so we have twilight shifts on duty. There's still more work to do. We've had considerable improvements with complaints, the reduction of complaints, because challenges are dealt with at a much earlier point in that process, and access times has improved. But we've heard today, and thank you so much, Stephen, for telling us your experience and reinforcing there is so much more that we need to do for the pathway and for our service users and carers that need to access 111. So thank you.
Thank you very much indeed, Kath. So just for the minutes, if I may, Rebecca is going to reach out to Stephen with his permission to talk about how we make our communications more welcoming. Jason's going to take forward the idea, brilliant idea, of video link. Tricia rightly asked the question about whether or not we know whether there's issues relating to weekend services, and we'll come back with a full response on that. And we'll also be looking at crisis provision, both in terms of the idea of a kind of a hotline, as you described it, Stephen, but also more rounded provision within Lowestoft as well. So those are the agreed actions that are coming from that discussion. Can I just say a huge thank you to you, Stephen, for being here and for being so clear as to why we need to improve this service rapidly. Thank you. Great, let's move on, shall we, to the next item on the agenda, which is the Chair's report, which I'm going to take as read, but I'm going to raise three things in particular. So as Chair, my focus remains on tackling three things: tackling racism and inequality within NSFT, putting carers right at the heart of what we do, and championing innovation that makes a tangible difference to our service users. Can I start with the first of those? And can I actually start with the SNE ICB Can Do Awards, which I've set out in my report, but I want to highlight that Priscilla and Zunenda received recognition in winning the Inspirational Leader Award, which was absolutely fantastic. We know what Priscilla is doing in terms of leading our listening into action, and she's also taking forward the reciprocal mentoring scheme, which is so vitally important. It's delightful to note that a member of staff is here who's participating in that scheme as well, and you're very welcome indeed. And we're looking forward to seeing progress being made on that, but Priscilla really does show what inclusive leadership looks like in practice. So the other finalists were equally impressive, and I've listed them all in my report, but they were all there on the day, and it was absolutely fantastic, bright, sunny, beautiful location, and we just had a tremendous celebration. It's really extraordinary what our staff are doing quietly everywhere. In terms of carers, we had a brilliant carers information day at the forum in Norwich. It's always a great day. I'd encourage people to get out there. It was lovely to see so many of our governors there as well, so thank you very much indeed for that. And we launched the further consultation on our carers charter, which marks a further step forward in making a reality of our ambition to ensure that carers are a part of everything we do. And then when it comes to services innovation, I had a visit to the Central North West London Accident and Emergency Department, and it has completely knocked my socks off. I'm afraid I can't stop talking about it. Everyone I meet, I'm talking about it, whether they work in NSFT or anyone else I happen to meet socially. But it really was the most extraordinary experience that I found, and you have to remember I'm not a health professional, but to go to a calm, welcoming, 24/7 service for people in crisis where there's no complex referrals, they can simply walk in off the street. There's a consultant psychiatrist and a huge team of fantastically experienced nurses and other professions who will treat that person there and then. They're assessed within 10 minutes. And you see the testimony from the service users. There's none of that disruption and anxiety that's involved in being in an acute hospital A&E, and the outcomes for service users are absolutely outstanding. And I'd add that the outcomes for the trust in terms of money saved, in terms of the whole system, are extraordinary as well. So I've left that with a clear ambition. We've talked to Caroline, we've heard from Stuart and others who have been to visit other services. We all have a shared ambition to see how we can introduce the right model of something akin to that in Norfolk and Suffolk. It's really important that I warmly welcome Eric Crossfield as our new Deputy Lead Governor. We're really lucky to have you in post, Eric, and delighted that you're stepping into this leadership role with all of your vast experience. So thank you very much indeed. And also a big thank you to all of our governors who are now observing our board committees, which is a really constructive step in terms of strengthening our accountability. I'll say a very brief word about our leadership conference at Trinity Park, where we brought together 300 of our leaders from all services, professions, and leaders at all levels within the organisation and all geographies to connect and focus. It was great to hear the experience of the speakers that we invited. It was a great day. But what was really important for me was the conversations that I had kind of in the fringes, where staff were coming up to me sort of without me encouraging it and just saying it really does feel different now. We do believe that this change is happening and it's going to lead to embedded improvements and for good, and that was tremendously encouraging. So I'd just like to finally thank everyone who's working so hard, both on this board, to drive that improvement. It is relentless, I know that for you. I'd also like to thank our staff and put on record that it's really tough for our staff to be continuing to drive this improvement through all of the change that's being experienced by them and the uncertainty. But I'm delighted that we're embracing that opportunity that the change will bring for the better. So we definitely are still on a journey. We're not losing that sense of the humility that we have in terms of we still need much more to do to improve our services, but I do think the direction now is really positive and really clear. Any questions on the Chair's report? Helen.
Thank you, Chair. I just wanted to add my comment on the leadership event, which I attended, and I agree it was a fantastic event. It was really good to feel the kind of energy with leaders and really stimulated by the inputs. So really good day. And just wanted to comment as well that you've reflected on the mental health emergency department. I think it would be really helpful if, I'm sure it's sort of in plan, but as a board we could start to have some kind of thinking time and conversations about the NHS plan and where that takes us, because as you say, we're on a massive improvement change journey, but the opportunities around where locality fits with neighbourhood, the digital opportunities, etc. would be really good.
We'll definitely take that up, Helen. That's going to be planned in for the September development session, so absolutely it's really important. I think Caroline might say something under her report on that as well, but yeah, thank you for those comments. Any other comments? No? Can we take my report as noted? Thanks very much indeed. Can we now move to the CEO report? Caroline.
Thank you very much, Chair. And again, I'll take the report as read. I wanted to just particularly highlight 5 points, if I may. First is the appointment of Tom Davis as our new Chief Delivery Officer. Really fantastic appointment. Tom is unfortunately on leave today, otherwise he would have come in attendance, and he will join us at our next board. He starts with us in a couple of weeks, so it's a great appointment. And will oversee strategy, planning, major change programmes, all of our governance, including our board governance. So great, and many congratulations to Tom, and thank you to people that were involved in the appointment. Second area I wanted to just mention was the National Oversight Framework. So colleagues will know that we've moved into National Oversight Framework 3. We have 4 National Oversight Frameworks as of last month, and we've moved from 4 into 3, which is indicative of our improvement. As part of that, we no longer have any ICB colleagues on any of our committees of the board, because we are seen to be sustainable enough to lead our own improvement. And obviously our improvement director support went at the end of last year from NHS England. We now, as colleagues will be aware, and something, Helen, we need to talk about some more when we come into board development, is the new performance framework that is emerging, hasn't yet been published, but will be imminently, and is looking quite different. So we're going from 4 levels to 5 levels, and where 1 is the most highly performing and 5 is the most challenged. And each of the trusts with the Secretary of State's leadership is going to be ranked for the first time. So we will know where we rank according benchmark with other trusts in England. That hasn't been published yet, and obviously we will bring it through into future committee and board. But it's really just to note that the framework is changing, and that we could find ourselves back in 4, even though we've moved to 3. What is also important is that the financial position is a significant influencer on the framework. So if any trust has any deficit support or is in financial deficit, there's a limit of the level of the framework that they can progress through. So again, it's something that we need to consider in a lot more detail. There are, for mental health, there are only 9 metrics out of 30 that relate to us. One of the significant issues in the mental health sector is it doesn't have the same level of performance scrutiny, which I think is a disadvantage, because that can link to investment, and gives more transparency of operational and performance issues, and particularly access to services. So something, again, I'm sure we'll want to discuss some more. So we're trying to get our heads around really quite a complex framework, and we'll bring it back into our next development session. Third area I just wanted to highlight was the work that Kath is leading on, really importantly around health inequalities. We have a suite of enabling strategies, 5-year strategies, including our trust-wide strategy, and we will now be developing a strategy around health inequalities. Kath will be bringing that back to our next board. There's a series of workshops, both internally and with partners, that Kath and her team are leading, and people with lived experience are clearly absolutely front and centre of that. So it's just an important development for us as an organisation. Fourth area is CQC. So we, as everybody knows, we've had an inspection from CQC in 2 of our core services, our community adult services and our crisis, home treatment, liaison and health-based places of safety. We have received our draft reports, and we are going through those at the moment and be returning them imminently to the CQC. And again, we will be bringing those into our next board meeting, and we anticipate getting our well-led reports August, September time. And my final area to raise is a lovely one, which is our Talk Awards, which is fairly newly introduced. We introduced in April a monthly Talk Awards, which is our values, celebrating people across our organisation that are demonstrating our values. And we have every month now in each of our localities and corporate services 1 award winner that's identified, and then an overall winner for the trust. And the last 2 since we've last met are Comfort Oki. People may remember when we had our race conference that Comfort got up and articulated the wonderful poem that was written. And she's also an access and assessment nurse practitioner. And also Pauline Curtin, who works in our liaison services as a practitioner. So really big thank you, an important development for us as we continue to celebrate the really good practice that's going on at the same time as continuing to improve. Happy to take any questions. Thank you.
Thanks very much. Very comprehensive Chief Exec's report. Anyone got any points or comments or observations they'd like to make? So much going on is my observation, but thanks very much indeed, Caroline, for that. Let's move on now to the Trust Strategy Update and Improvement Programme. Caroline, that's yours as well.
It is. It is, thank you very much. So colleagues will know that we have a very clear strategy: improving health, improving care, improving culture and improving value, supported by our enabling strategies and our 12 major change programmes. What this report gives you is the headlines of, really importantly, progress against the strategy and assurance that the monitoring of that happens by the executive team, chaired by me, on a monthly basis. One of the things that we are working on at the moment is to align the 12 major change programmes with both the board assurance framework and the performance framework, so that we really try and have a seamless approach both to our improvement and management of risk. Stuart and Tom and Ade are working on that, and we'll see some more progress in our next board. Happy to take any comments, questions from anybody.
Great, thanks very much. Anyone? Yes, Linz.
Thank you for the update. So it would also be good to know how this aligns in the future to the 10-year plan that Helen has already mentioned earlier. So, and then just when I was reflecting on the amount of change that we've got within the trust, something that comes through in a number of our chairs' reports from committees, there's so many things on here. I wonder if there is a danger that actually we end up with some bits, there's interdependencies within here, that if we miss one thing, then the rest will fall over. And I'm thinking things like some of our major change goes into our EVI, or efficiency value programme, improvement programme. So what interdependencies are there, and which ones do you think needs to have the most close watching brief on to ensure they do deliver?
Thanks, Lynn. So just on your first point in terms of the 10-year plan, really good point. And of course, it's fairly high level, the 10-year plan at the moment, and we're anticipating that we're going to have an operational delivery plan. But the timescale that hasn't been confirmed but verbalised is in the next 6 months. So, and particularly one for mental health will be welcomed, but an important point for us to consider, particularly in the development of next year's plan. And because when we developed our 5-year strategy, we said it's not going to sit on a shelf, it's going to be updated year on year, and the major change programmes is the anchor of that strategy. Secondly, really importantly, in terms of the read across, and there are a whole load of interdependencies. In fact, I don't think any one of them sits in isolation. So if we're looking at our clinical transformation programme, that completely aligns with the involvement of service users, carers and families. It aligns with the outcomes of that transformation is measured through the clinical standards programme, for example. The EVI programme, there's a really strong read across with the transformation programme and the EVI programme, but also into the workforce programme, for example. So we absolutely, and what we're looking at all the time is, can we rationalise the governance so we don't duplicate? And we've done quite a lot of that. I still think there's more we can do. And it's just an ongoing discussion for us. And hence we all meet on a monthly basis to monitor this. We've just had some time out last week as an executive team to really look at our meetings and governance structures and see how we can rationalise them further. So hopefully that answers your important questions. Thank you.
It was a really good question. I had a similar thought when reading the papers. I think we've got to be quite disciplined in all of our reports to signpost to the large-scale change programme when we're talking about the areas that we're looking at through board, committee boards in particular. It may be that there's some changes, slight changes we could make to the kind of the delivery heat map that makes that job a little bit easier, I would have thought. But I think fundamentally what we're talking about here, these are the building blocks to becoming an outstanding trust. And we need, I think really, Lynn, the answer that I'm hearing from Caroline, I'm just going to check, we've got to do all of this. And if we don't do all of it, it ain't going to happen.
Yeah, I mean, I think definitely, and I think there's more we can do as we continue to mature, to align. So if we are picking up new risks that are coming up through both operational and into committee, then how does that, are we therefore giving the right resource and leadership attention on that risk, and how's that reflected in the large scale change programme? Nothing, everything should be dynamic. So, and that's the work that Tom and Stuart Addy are doing at the moment. Thank you.
David.
Just a quick observation. I mean, I'm really pleased to see this because for me, this is essential executive management tool. You've been in place, I think, for about the last 12 months, this approach. And I think the fact you're reading the covering report, it's also a dynamic approach. So it's taking account of changing circumstances. So I just wanted to make the point that I really welcome it.
Yeah, encapsulates the extraordinary journey that we are on. Thank you. No other comments. So could we note the Trust Strategy and Improvement Programme, please? And while we're at it, could we also note the Chief Executive's report and the Chair's report? Not that anyone noticed. Could we do that, please? Thank you. Great. Okay, let's move on to the Board Assurance Framework and Risk Update. We've got a report. Thanks very much. Is there anything further you wanted to add to it, Ade?
Yes, thanks, Zoe. Really just a couple of things to draw to Board's attention around our overall approach to risk management, but also the BAF in particular. We continue to work really closely with both our locality teams and corporate teams on improving our overall approach, not just to risk management, but also to governance. So the risk team are rolling out, as part of their sort of regular training provision, a more holistic approach to governance, particularly focusing on the new locality leads that we've got in place across localities, just supporting the work they're doing, but also giving our frontline teams a bit more understanding of governance and giving them the tools to be able to do that work themselves within their areas. So that's something, again, we're just rolling out, but hopefully will be a part of a wider provision as we go forward. And then the other thing I just want to draw to colleagues' attention in terms of our overall approach is the work that we're doing, and I've sort of mentioned it at some of the committee meetings recently, just to take the opportunity to start to review our overall approach, bearing in mind we've now had the improved, so we've rolled out a new risk policy now the last 6 months or so. I think it's a good time to now to start thinking about what is our approach and how can we make it, how can we answer the question more, what next, and how does this really help us on our improvement journey as an organisation? So we've got the process right. It's now a case of, how do we build on it? And that's work that we're just starting to do, and our work with the committees will be really helpful in just getting their feedback on where they think we can improve and where they think we can take this going forward. And then just the last thing I just wanted to raise in my introductory comments were around some of the more specific work we're doing in the BAF. So in relation to our mental health legislation work, the Chief Medical Officer and I are working on, and the Head of Risk are working on, better reflecting our mental health legislative risks within the BAF and deciding whether to do that within the context of an existing risk or to create a completely new risk around that. That's work that we're doing with Helen as chair, and as I said, with Faisal and myself leading on it from a risk point of view. And just finally, again, just wanted to draw the board's attention to the fact that we now have a new risk on the BAF around our approach to emergency preparedness, and which will be managed by the Chief Operating Officer and will be overseen by the Performance and Finance Committee. So that's all I wanted to say. I'm happy to take any questions or discussions.
Thank you very much indeed, Ade. I see Tricia.
Yeah, just a couple of things. I mean, I really welcome this idea of driving down the ownership to localities and as far down the organisation as possible. The numbers are low, And I know you're running lots of them, so I think we need to keep our eye on that and make sure that you get as many people through that as well. And the other thing, as in my report, we have a new CPO, we have Jeremy in place, so the committee has asked, he's given a little bit of time just to look for the clarity and relevance and risk ratings in respect of people. And I think Jeremy's going to come back by September, October meeting for that.
You've got a nod there, which is good. Thanks, Jeremy. Lovely. Great. Thank you. Jason and then Helen.
Thank you. It's a general comment in terms of the board assurance framework and the previous agenda item, actually. And there's a clear read across from the board assurance framework into the large scale change programs. And I think that gives the golden thread between the way we're managing our risk and the way we're planning to do the action off the back of that. And the large scale change program effectively mitigates and manages some of the risks that we've got within the organisation, and the read across is clearly there.
And much more clearly articulated in the papers and the BAF itself, which is really helpful for us to kind of keep track of where we're heading on all of this. Helen, and then
Thank
Liz.
you. I just wanted to pick up an issue about, or a question really, about risk 3.4, which is about transforming clinical pathways, because the notes say the risk score was reduced in March because we were no longer NOF4. But I wonder, in the light of the bed census, and I know we're going to be talking about that this afternoon, that shows there's still a lot of work to do on flow and people being in the right place at the right time. Just a question whether that is the right level for us.
Yes, good challenge, Helen. Thank you. Who would anyone like to answer? Oh, Stuart, thank you.
Yeah, take your point, Helen. I think it is something that we are going to have a look at. We've just completed the bed census for older peoples and just waiting for the findings for that as well. I think once we've got those two things together, it is something we'll have to look at, and whether or not we have to raise the risk on that. Let's have a look and see what we need to do. We'll bring that through the committees.
Good, thank you. Linz.
Thank you. I just wanted to pick up in Julian's absence one of the items that we looked at in Audit and Risk Committee, and that was around the role of the Risk and Policy Group. So we really recognised in the last committee that there was the appropriate level of attendance at the group, and you can actually see now what they're doing. They're really finding their feet, and that's really helpful for them to do some of that heavy lifting in the nuts and bolts of risk management and taking that out of what was in Audit and Risk Committee. So it's a really good development, and keen to see that continue. Always more to do, but a really good start.
Can I add a bit to that?
We're running over time.
Okay.
I think it was a helpful observation. Thank you very much for that, Linz. And any other comments on the BAF? I'm being really strict. We had 5 minutes on the agenda for this item, and we've already had about 7.5. So, okay, that's great. I would like also to know when we're going to be deciding whether or not we need a separate risk around the mental health legislation responsibilities that we have. Does anyone have an answer to that?
Yes, that's going to the next meeting of the committee, and then will be brought to board.
Oh, great. Okay, lovely. That's great to hear. Thanks very much indeed. So with that in mind, could we note the progress of the BAF mapping and transition plan, which is at Appendix A, and note and discuss, which we've just done, the latest version of the BAF. Is the board happy to do that? Lovely, thanks very much. Let's move on to the Integrated Quality and Performance Report, or IQPR as it's fondly known. Stuart's going to walk us through this report. We're setting aside a really good chunk of time, 1 hour, in order to be able to walk through that report, look at the alerts, advises and assures as appropriate, and we will be incorporating into this part of the discussion the Chair's reports for quality, performance, people and culture, audit and risk, and probably mental health at the end. I'm hesitating because Stuart and I discussed this before the meeting, and I hope I've got that right, that he will correct me tactfully if I've got that wrong. Over to you, Stuart.
Thanks so much, Chair. Okay, so I will be bringing people in. I'll go through the IQPR. I'll bring the relative exec leads in, and then I'll also bring in the chairs of each of the committees in line with the IQPR. Two papers in your pack. I noticed they joined today. We'll need to have a look at that. There's the Alert Assure Advise report, which is a summary document. And then at the end of that, there's also the more detailed IQPR report. Just some information on development that's happening within the IQPR and the QPGs, the Quality Performance Group reports. We are doing a lot of work. We are aligning those with a real read across to the large-scale change programmes. That's in train now. So we'll be able to say that quite clearly in future reports. And then there's a lot of work already happening. We are going to try and close the gap. If you notice, we're in July's board today, and we're reporting on May's data. And we want to close the gap on that, so we're actually reporting on July's report on June's data. So in the coming months, we will be able to sort that out. Aaron Fairlamb's now joined as the Director of Performance for the Trust with great experience. And he's got some real plans to try and improve the IQPR and QPG packs for the Trust. We're doing a lot of work to try and add additional metrics. Metrics we've talked about, so things like carers metrics being added to the IPQ and the QPG packs. And then also a lot of other sort of metrics that we're being asked to do. We've got now a priority list, and we're working through that to be able to add some more quality into the IQPR report moving forward. Moving on to the IQPR report itself, I'll start with improving health. And there's a few areas I would like to discuss. Not surprisingly, out-of-area placements is something I would like to discuss. We did see a drop in May, where it dropped down to 28 out-of-area placements at the time. We had 22 in Norfolk and Waverley and 6 in Suffolk. We have had a look at that and found that we did have a lot of patients who were classified as clinically ready for discharge in our beds, and it's something we are looking at to try and improve flow, to try and get those patients to where they need to be, which is usually in the community, and therefore freeing up our bed stock. But we also did admit 2 patients over 65 out of trust into an out-of-area bed as well during that period, so something we are looking at. And I know I'll bring Andy in to add some comments to that particular area. Another area I'd like to discuss is very urgent crisis referrals, same within 4 hours. We have a current figure of 56.6% against a target of 95, so we're not doing particularly well in there. Lots of work happening across the Trust, and we can touch on that in the crisis report that I'll bring in further down the agenda on the work that's happening to try and support that and get that work to a much better place. We do have targeted plans, particularly for Central Norfolk, being led by the coup, to try and get Central Norfolk, who's a bit of an outlier, to a better place. And we are still embedding the crisis standard operational procedure. And we are seeing greater consistency with the introduction of that, but it hasn't translated yet into measurable improvement, so we hope to see that in the coming months. And then the last one I wouldn't mind raising is the NDD weights, which is the neurodiversity disorder weights for 18 weeks. We are making good progress to plan on that, and we have got an agreement with the commissioners to provide additional support for funding to try and reduce that waiting list. We have been working with the locality group in Suffolk to look what that new pathway might look like, and we think we could reduce the waiting list from national issue for 4 years down to 2 years with that additional funding and that additional pathway redesign. So work underway to look at that as well. I'll bring Andy in at this point and see if Andy's got anything else he wants to add to that.
Thanks, Stuart. I'll probably just talk a little bit more about the 2 areas you've picked up on, so the out-of-area crisis pathway, but also the NDD pathway. If I start around the NDD pathway at the moment, I think 2 things to mention, specifically around children and young people in Suffolk. There's been some really good progress in terms of looking at what the current offer is. There is, as Stuart's mentioned, the potential to reduce our current wage from 4 years down to 2. So we're in the process of agreeing with Commissioner some non-recurrent funding to reduce that waiting list, which will help significantly, and that will begin looking at the longest waits that we have. We're also going to go through a process of contacting everybody who is on the waiting list, because we need to establish whether they are still waiting, given that some of them have been waiting a number of years. So it's really important to do that in that space. As well as the additional funding, the team have been focusing on the operating model within the service, looking at trying to increase the efficiency through productivity to try and get to above 50%. And we're confident the team can do that, and that will help keep up with the demand in the longer term. So once we've reduced the waits, that will allow us to stay, to continue to consume our own smoke, so to speak. We're working with a third sector digital provider and QB testing within the assessment process, which will help us to further increase the productivity in that space. And then we're doing the wider transformation piece, looking at a horizon scanning project so that we can identify what other areas are doing other systems and providers to inform the potential around what pathway we will move to in the future for children and young persons, NDD pathway, and that'll include digital technologies, working with other partners within the system, such as our primary care partners, voluntary sector and social care, to make sure that the model is sustainable longer term. The other thing to mention in NDD is around adults across Norfolk and Suffolk. We've seen the establishment now of a task force, very grand term for a working group, I think, across the two counties, represented by both SNEA, Norfolk and Waveney ICB, and ourselves, with a specific focus on baselining the current capacity and demand across the services, identifying any short-term wins across the two counties, and again looking at what is the sustainable strategy and model to deliver care for Norfolk and Suffolk in that adult space. So there is some progress around NDD, which I think is progress, because previously we struggled to provide that narrative, so I think there is some encouragement there. In terms of the out of area and crisis, important to acknowledge we saw a significant period of increased demand through June. So that began really at the start of the half-term period. For those of you who remember, there was a half-term in that. So there was a national spike in demand in that period. Interestingly, the demand showed through our emergency departments and our 136 routes into services. So we saw extremely high numbers of people in ED departments who required admission into bed. That saw us move from the reported 28, which is in the IQPR. We peaked at having 50 people in out of trust beds again. As of today, we've reduced that back down to 32. And there's further 2 discharges planned this week, so we're hopeful that we'll end the week on 30. Stuart mentioned that there had been 2 people, 65 plus, as one of those remains out of trust and being brought back. It's important that we have a look, although it's a national pressure, it's important that we look at what the shape and the profile of those admissions were in that period to really understand what the clinical need was. I know I've spoken with colleagues from Central Norfolk locality who are beginning a piece of work to have a look at what the diagnoses and presentations were for the admissions in that period, and we can come back to board of that at a future date to have a look at it, what we can learn from that. I guess important to note that in the reduction that we have managed in this month, some of those have been our longest staying individuals in out of trust. So particularly in West Norfolk, where we had people who had been there for an incredibly long time who have now been discharged. And there's a different approach being taken to how we repatriate people to discharge them where they've got stuck in some of our out of trust beds.
I'm going to hurry you on, Andy,
Yep.
please, because I want the board to have a discussion on this about the what next. So carry on, please.
So if I jump a bit towards where we're heading, so I went to visit Lincoln recently in terms of what the mental health ED offer is there. They had currently at the time 0 patients out of area. We've also got in diaries to go and meet Central Northwest London to have a look at ED that I know you looked at, Zoe. I think there's some real learning for us around how we make maximum optimal use of the pathway that we have, around making sure that we provide alternatives for people to come into hospital, that the culture that our staff is following is one that's based around the least restrictive environment and being as compassionate, as kind as we can when people look for help. That's one of the main things that we've spotted when we're looking into other areas, is that willingness to ask people to come in and see them sooner in the pathway, so that we can offer an assessment that avoids the need for hospital admission. And I think it's that next stage that we need to start thinking about and talking through.
It's complicated, isn't it? Because everything is connected. And I get that, but thank you very much for explaining that, Andy. Right, are we going to pause there and ask for questions, or should we bring... Why don't we do that, and then there's a lot to take in on this section, so can we pause after that and just have some comment and discussion? Linz.
Thank you. So at the Performance and Finance Committee this time, we had 2 core pieces of work that related to the alerts. The first one was an update on the EVI programme specific to the productivity work stream, and Andy gave a really fantastic presentation over the work that was going on with this, which you've already alluded to. Part of this also links in with the concerns that were raised at the committee over the financial ask of the trust, and the current position on recurrent and non-recurrent efficiencies. So at the moment we're doing better on non-recurrent to recurrent, which gives us a problem in the longer term. So not necessarily this year, but going into future years if we can't get the correct level of recurrent efficiencies. But Jason, I'm sure, will say more on that in the finance section. So the other area that we also looked at was the bed census review that links in with the out of area position at the moment. Now that bed census review really generated some cross-cutting discussions across not just out of area, but actually also flow, culture, quality, and there's a reason that's coming to our board in private for a strategic discussion before it comes back at a later date with action plans. Overall, it was a really good deep dive into those 2 areas, and a really helpful discussion on the what, so what and what next. And we mapped out and planned when things would come back to the Performance and Finance Committee so that we could track and see the improvements.
Thanks, Linz. That's really clear, as is your report. Can we just, as we go through, could we note the report of the Performance and Finance Committee, please? And obviously within that we'll pick up some discussion on this as well. Stuart, back to you.
Yeah, so that's the improving care section done. I don't know if you want to pause now. Improving health, sorry. I don't know if you want to just pause now for questions on that section. So
okay, let's see who would like to ask questions, and I've got Kath.
Thank you so much. I'm particularly picking up the issue of NDD and the weights. I was really pleased to hear about the task force that's being set up. There's a couple of points I just wanted to raise. We need to make sure the task force reflects, membership reflects people with lived experience to ensure that we're hearing from people who are struggling to use services, and they, that their input is vital. As part of that, I think it's just important to recognise that we have a non-recurrent service commission from SNAES, Suffolk and North East Essex, ICB, within our recovery college for people waiting on the ADHD pathway. And so as part of that task force, I think it'd be really helpful to understand the learning so far on that, because that may form part of the solution going forward. And the third thing I just wanted to say as well, I read, as part of my role, I read every single complaint response that goes out. There is an absolute theme about people struggling, waiting on the wait list for NDD assessments and treatment. So I think, again, the experience lens needs to be really front and centre in that task force in order to make sure we're getting our solutions right. Thank you.
Good challenge, Kath, is it, Andy?
Yeah, Kath, agree with all of that, and make sure that's taken back into the task force.
Great, lovely. Got Jason, and then Caroline and Roger, and then David.
Thanks, Chair. Yeah, my comment was also on NDD, and as Andy alluded to, it's great that we've got a plan to improve the waiting list from 4 to 2 years. But I don't think anyone sitting around this table would accept that 2 years is where we want to be. And I think we need to be challenging ourselves to increase the productivity within the service to get that down, but also challenging our commissioners to be commissioning an appropriate level of service for the population we serve.
Yeah, well said. You stole my question, Jason. Shame on you, but very good question, I thought, because we don't have an ambition to get the wait list down to 2 years, do we? I think we should just note that that's not the position we want to adopt. And I'm going to take Chair's prerogative because I'm going to ask my question on the back of that. My second question, which is what percentage of those children waiting on the NND wait list, when we do eventually see them, receive a diagnosis that they have neurodevelopmental delay, if my language is correct? What percentage of all of those children waiting actually receive that diagnosis? Andy?
I'll step in, but not to give you the percentage, I'm afraid. I'm not quite that quick. It's a really important question, Chair, and I think it's one that we just need to come back to in terms of understanding exactly what that percentage is, because we do know that it's not all of the children that are coming through that pathway that get the diagnosis. It's important that we get that detail.
I think it is really important. I think the importance is we understand whether there are other means to triage that list more rapidly, so that a 4-year wait doesn't end in potentially what some may see as, you know, either relief at a diagnosis or disappointment. So I think we just need to be very careful on that. Andy?
Just really quickly, that's a key part of the work that's happening now is actually looking at that triage stage to make sure that people are going down the right route.
Is this on this, Kath? No. Okay, all right, thanks very much. Thank you, Jason, for that excellent question. Caroline?
Oh. Thank you. I just wanted to clarify that when we talk about out of area placements, that we haven't got any patients that are out of area. It's out of trust. So it's where we're supporting people within Norfolk and Suffolk, but in the private sector rather than our own beds. It's just important for us to just keep emphasising that from a quality perspective. Is that a yes, Stuart?
It is a yes, and just to confirm, part of the development of the IQPR, we will be showing that quite clearly moving forward. And we're just working through the metrics, so we align the metric the way it should be aligned to the national standards.
Thank you. And my second question, if I may, is around eating disorders, and ask that can we please do a bit of a look at eating disorders, because we need to get more assurance that we've got a clear plan for improvement around children with eating disorders, which we're failing the national target around, please. Thank you.
Is that to come back at another date?
Well, I'd ask the Stuart takes the lead with Gary and brings it, obviously, from a management response into the Performance Committee, and it sits in the Performance and Finance Committee.
Lovely.
Thank you.
Thank you very much, Caroline. Roger, and then David, and then Kath.
Thanks very much, Chair. My question is more of a comment, and it's a little bit philosophical. The Trust has been on a very, very good improvement journey. A lot of what we've heard just now, and with the service user presentation, have been examples of where service users have to fit in around the routine and systems of the Trust rather than the other way around. So when we hear about productivity issues, as a Trust, are we going to be moving to a 7-day, 24-hour-a-day service, using the A&E analogy, to make it really good outcomes for our service users? Because at the moment I feel that we're still on a 9 to 5, Monday to Friday rhythm to a large extent. So not a question, but comment.
Well, we can turn it into a question with a question mark at
the
end.
Question mark added.
Stuart.
Yeah, great question, Roger. I think you're absolutely right. I think we need to be pushing the organisation and the services we provide to fit exactly what the need is for our service users, carers and families. A Tuesday on a ward should look exactly the same as a Sunday on a ward in terms of what care is available. And I don't think it's any different for community teams, particularly our Category A services, crisis, psychiatric liaison, inpatient services. They should be 7 day. They are 7-day services now. But we need to make sure we've got the right level of response and the right level of resources, the right skills in those teams as well. I'll give you an example, which I'll talk about later, but 111, for example, capacity and demand showed us that actually we had a shift handover that was happening exactly the same time as the peak demand on calls. So, you know, just one example, I just need to have a look at it, get an understanding with data and our information, and then put the right levels of sort of support in place.
Really great question, Caroline.
Just brilliant question, and one that is at the heart of some of our deep cultural issues. I would say they are national issues, and particularly around, with the acute sector, felt the pain some years ago in moving much more to a 7-day service. And I know there are still challenges, but mental health culturally has been much more of a 9 to 5, Monday to Friday. And completely, we'll hear some more in terms of the Ben census, and one of the recommendations around that is strengthening 7-day in our crisis services. But I also encourage us to think about community services. So from elsewhere, it can be really a win-win in terms of flexible working for staff, because some staff with caring responsibilities, they quite like to work in an evening. It can suit them better, pick the kids up from school and have a twilight shift. And that's then can help to offer more services into maybe up to 8 or 9 o'clock in the evening in our community services. So as we do our transformation, I think we should be just thinking more broadly than just 24/7 services. Thank you.
It was interesting that Central North West London, not that I'm doing a kind of promo for that trust, and Claire Murdoch, if she's watching, she'll be very grateful to me. But one of the transformative actions that they took in their trust in terms of increasing flow, reducing out of area placement, and overall increasing the patient experience massively was daily ward rounds rather than weekly ward rounds, which kind of makes perfect sense, but I think we need to be really clear about what our ambition is here as a board. Good. I can see everyone's dying to answer that one.
That's key. Absolutely.
Okay. Thank you very much for opening that. I'll move on to David, if I may. I've got a tick by your name, but I don't think I've asked you to speak on this yet. Have I?
No.
Good.
Can I speak now?
Yes.
Thanks. Going back to the NDD issue, I mean, absolutely right, and I'm really pleased that we don't have an ambition for 2 years. But you just think about people waiting that period of time. It is a lifetime for people. And I just wonder, obviously this is part of a national issue, whether there's been a dilution in terms of the referral criteria. Whilst I really support the work that's mentioned in the paper, what work are the commissioners and we doing with the referrers in terms of realistically looking at what referral criteria should be? It may be part of this, but I don't get a sense of that.
Thank you, Andy. Yes.
Yeah, thanks, David. I think it's a really important question. I don't think we've got like a complete answer in terms of what the way it's doing. I think it's one of the conversation pieces in the task force and in the work that we need to do. I think the demand has gone. We all know nationally the demand has gone through the roof really, and I think the routes in have increased as well. So of course we've got numerous ways to access. Or to come into our services for a diagnosis. So I do think there's a lot of work needs to happen across the system, and I think there is recognition within the work, the task force around this is stuff that's got to go wider than just the NSFT. It's local authority, it's primary care, it's schools. So we just need to work both really hard on understanding how people access services, but also on Chair Zoe's point earlier around what we do at that point of triage, because I think it can be a really difficult journey for a young person or their parents when you are referred to a service, taken on, put on a wait list, only to find out 2 years later that actually you didn't need to be on that wait list in the first place. So I think there's work to be done both with the referrers and the criteria, but arguably, more importantly, at that point of triage, because sometimes it can be difficult to be really definitive about what that criteria is.
Yeah, I think this is a place where we need to be picking up best practice from other trusts as well, because other trusts are doing some quite advanced work in these areas. Okay, great. So thank you for that. I've got Kath. Briefly, please, Kath, because you've already come on this item, and then I've got MC.
Lovely, thank you. I just wanted to go back to the older people that were placed in an out of trust placement. And we made a commitment as an organisation, probably predating many of us around the table, that we wouldn't do that. We wouldn't send people who are older to inappropriate placements, and that was following the death of Peggy Coatman. So I think we need to challenge ourselves as to how that happened, what the level of risk assessment that was put in place to allow that to happen, and to be assured that we're not slipping in relation to continuing with that obligation. And I think it links to the bed census that you've mentioned, Stuart. We know we will hear when it concludes there will be many people occupying our older people's beds that don't need to be in them. So our beds need to be available for people who need them, and we need system partnership support to help with people leaving those beds when they no longer need to be there. Thank you.
Yes, thanks, Kath. Obviously, the tragic death of Peggy was awful, and we have drawn lessons from that. I just want to check the two elderly people the over 65s who are in out of trust placements. Are they out of area as well? So it is very different, Kath, because we know that Peggy was taken to the south of England, the southwest of England, miles and miles away, which was the real issue. And I think this is quite different. And all is being done now to make sure that we're not seeing our elderly service users and patients being transported. MC.
Thank you. I'll keep it brief. Just an ask really that we spend some time outside of this board meeting being really clear what our collective definition of great looks like when it comes to mental health services. So much of what we're talking about today sees marked improvements, but you know, Zoe's right. Our ambition is not to go from 4 years to 2 years. It's not to go from 52 people out of trust to 30. That's not the dream. That's not what we're all here to do. And so I think particularly for those NEDs who don't come here with a clinical background, making sure that we've also got some time to be really kind of quite visionary in what it is we want to deliver for our patients and their carers and families would be really helpful. So and making sure that we've got some time to schedule that in would be really helpful and provide, I think, some hopeful context to some of the IQPR, which is really improving, and I'm really grateful for the kind of clarity in this report.
Yeah, I think that would be really helpful. I think it would really help with our narrative as well as we go out and talk to people about what this transformed trust is actually going to look like in 1, 3, 5, 10 years' time. Obviously, I'm not suggesting it takes 10 years to get there. I think that kind of, you know, from improving to great has got to be our ongoing narrative. Great, thanks very much for that, MC. I don't see any other questions. Are you going to summarise, or would you like me to, Stuart? Well, I'll do my best and then you can pick up all the bits that I've missed. Is that a deal? So we are going to set the ambition to eradicate weights on the neurodevelopmental pathways. We're going to come back to Caroline on the eating disorders point. We're going to set an ambition today as a board and publicly that we become a 24/7 organisation, and all of our work will be focused on that. And as part of that, we're going to be clear what our ambition will be in terms of outcomes. Stuart, anything else? Right, okay, as a reward for that excellent discussion, we're going to have a 5-minute break, which isn't scheduled, but stretch your legs, come back at 11:35, please, and then we'll finish the rest of this. It's all right, Stuart. I know that we've not finished this. We're just going to have a break because we've been at it for a good hour and a half now. Thank you. It's lovely to see most people back.
Thanks, Chair. We'll move on to improving care now. So there's a couple of areas that I did want to pick up. There was no alert in the improving care section for me, but I did want to pick up a number of areas. So care plan compliance, we're sitting at 82% against a target of 95% across the organisation. Clinical supervision is another, which was sitting at 72% against a target of 85%. And then the third area I would just like a conversation on is the number of patient safety incidents in a month, which jumped and spiked at 6, 3% on Norfolk and 3 for East Suffolk. But I'll bring Anthony in to bring an update on those 3 points, please.
Thank you, Anthony.
Thank you, Stuart. I suppose just to add to your comments around the care plan compliance and the clinical supervision, we have seen an improving trajectory over the past 12 months, but unfortunately it's plateaued a bit of late. This has been picked up with our locality teams. We're having a weekly sort of look at these through the business delivery group as well. We've also started to look at this through our quality performance group meetings, and through my director of nursing meeting. It's one of the areas that we have highlighted as a priority for us. So we're hoping that we'll start to see that trajectory shift again.
Thanks, Anthony. I'll bring Caroline in.
Thank you. And it's really helpful, Anthony. Thank you. I guess that gives us a reassurance rather than assurance. And I wonder, Stuart, if where we're up to now with Alan recently joining us, on areas that are sticky, albeit we've had some improvement with clinical supervision, it's gone up and then going down again. How far off are we and the committee being presented with a clear trajectory for improvement so that we can focus on, are we delivering the improvement plan?
So, can I come in? Is that okay?
Yeah, please.
So Alan is working with the care groups to look at those trajectories of improvement, to report back in through the QPG, so the Quality Performance Group, on a monthly basis. So that's starting to happen now. So we'll start to see that, I think, probably in the September committees, to be able to see those trajectories for improvement.
So can we particularly focus on clinical supervision and care plans as a priority? Yeah. And then by the time we come to the next round of committees, there'll be a clear improvement plan, and then the committee can focus on that.
Yeah.
Perfect. Thank you.
And just to add on the 6 patient safety incidents that you referred to, Stuart, we've had 6, 5 of those have been deaths, and they're suspected suicides. But we don't know for certain at this stage. Obviously, they're subject to investigation. And then one was the incident involving a person who set fire to themselves. So that's the update on those 6 at the moment. They're subject to investigation. And there'll be a further report of the private board on the petrol station incident.
Yeah, because of the sensitive nature of that matter and the risk of identification, that is a discussion that is absolutely rightly to be had in private and will be challenged through the board discussion as is seen here. But thank you for that, Anthony. Okay. So we've got an action so far, which is that we have the trajectories for prioritising clinical supervision and care plans available for September round of meetings and the October the 2nd board. Is that correct, Stuart?
Yeah.
Great, okay, and that will enable us to see the trajectories for each of our localities as well as the overall trajectory. Okay, that would be really helpful. Thanks for that. Back to you.
Thanks, Zoe. So the only other thing I would want to mention around improving care is you notice a number of, I think we've discussed it in the past, a number of metrics that sit as outside framework, and we're just in the process of removing those and having actually either a direction of travel we expect to see, because there are certain metrics that we would be very unlikely to put a number on. Sort of, you know, we wouldn't want to put numbers on some of those particular metrics, but we will expect a trajectory for movement in terms of we actually either expect it to go down or expect it to go up, and want to know where it's going So we will be removing out of the framework and adding those in the next for the next IQPR. Okay.
Does everyone understand that? Good. That's fine then.
Thanks. I'll hand over to Roger now to provide an update on the Quality Committee Chair's report.
Thanks very much. Very, very quickly, at the risk of boring everyone back to the neurodiversity waiting list, the Quality Committee is troubled that it can't pin down the risk that's sitting on that waiting list. We don't need to discuss that any further. It's been well aired. I do want to move away from the negative in the Quality Committee. I've seen huge improvement in the good news to bad news ratio. There is far more good than bad, and I just wanted to highlight three very notable pieces of good news. The annual report from Learning from Deaths, which we will receive later, is a superb piece of work that has moved us from a position of real inadequacy to one of outstanding excellence. So well done to the teams for getting this sorted out. The second area that I wanted to highlight was the progress report from Listening into Action, which was inspirational, and the Quality Committee could see real change being driven by this going forward. So that's another big well done. And then the final one was related to the locality presentation from East Suffolk, where the committee saw excellence in terms of the maturity of the new management structure and their autonomous program of improvement that was palpable. So I just wanted to bring that to the board's attention.
Brilliant. Well done, Roger. Yeah, absolutely. It's really important. It's so easy, isn't it, to sit here and just your eyes get drawn to the areas where there's a kind of a red flag or an alert, but it's so important that we remember that this is a board that needs to see everything in the round. So we'll note the thanks that are being passed back to the teams for Learning from Death's annual report, the LIA progress, and also thanks to the locality team in East Suffolk for their presentation. And we note your report of the Quality Committee. Are we noting the annual reports at this moment, or should I scoop them up at the end and check whether anyone wants to raise anything specifically around the annual committee reports at the end? Okay, great. Thank you very much indeed, Roger. Back to Stuart.
Thanks, Zoe. Okay, we'll move on to improving culture now. And the one area I wanted to pick up in terms of improving culture, lots of sure metrics in the improving culture part of the report, but I did want to pick up the percentage of voluntary labourers not completing 2 years service, which is sitting against a 41%, currently 41% against a 30% target. We know that this is largely admin and non-registered staff that we're seeing leaving within 2 years. We are predicting further improvements over the next 12 months to bring it within the trust standard. We have got a people promise manager role that's funding has ended at the beginning of June, and we're considering, I believe, how we sustain sort of the improvements that we've had in that particular target for that particular piece of work. But I'll bring Jeremy in case there's anything else Jeremy wants to add around improving culture or that particular area of concern.
Yeah, thank you very much. So at People and Culture Committee earlier this month, it's still July, we had an end of project report for the People Promise programme that Stuart referenced, and that has supported an overall reduction in turnover through a number of initiatives that we've been able now to embed. So yes, the funding for the particular role has ceased, but the initiatives that we've embedded relating to improved induction, improved appraisal, recruitment improvements are now part of our everyday practice as a team within the People and Culture team. Having said that, this particular metric is still of significant concern. Stuart has highlighted two particular groups that stand out. So we've looked at the data around those particular groups, A&C staff and clinical support workers, and we are retaining a higher number of those than we were, but we still need to go further. That metric, as well as a rolling average metric, so we should see it come down over time in a smooth way, and there is continued work for me to do around understanding what's going on underneath that number as a metric that I've not seen other trusts measure. So much more to do.
Okay, thank you, Jeremy. Caroline?
Thank you. And I don't know, Jeremy, what depth of detail the committee has received. And also, manager, it'd be good to just bring this into a bigger issue so we can all have more transparency of it. Just thinking particularly around admin and clerical staff, A&C staff. We've had a listening into action programme, and one of the recommendations, which I'm absolutely delighted has now gone live, is for the first time we're just advertising for the first professional lead for admin staff across the organisation, something that the group really wanted. And I think that really helps, so they're a profession and they have career development in their own right. Absolutely key to supporting our services right across clinical and non-clinical. And I think in terms of clinical support workers, it touches on the conversation we started yesterday around what support and development have we got in place with our clinical support workers. So it'd just be really good to get a really good plan together, Jeremy, that's based on what does the data tell us, and then bring it back through both management group and into the people committee. And so we start to track it and expect to see an improvement. Thank you.
Can I just check one thing on the back of Caroline's excellent comment? And that's an action, by the way, that will bring further transparency through the management group and then to People and Culture Committee in respect of those that leave before 2 years. Are we talking about here? Just to be clear, right? Do we actually know why people are leaving? Have we got? You talked about the data, but have we got full disclosure through exit interviews why people have come and joined us, made a valuable contribution, and then left relatively quickly?
Yes, that's something we track and that we measure and that we record. Where we get responses from staff, and we do our best to get responses from staff to that question, that is recorded and used to generate these metrics.
Sorry, and that's really helpful. I guess it's the so what, isn't it? So I don't think, generally speaking, exit interviews are well systematised across the NHS, and I think something we need to put more effort into. But then what do we do from the themes from those? But what does the data tell us? What percentage are admin and clerical? What are healthcare support workers or clinical support workers? Are they leaving the organisation? Are they moving into different roles? And that's why we just need to all understand the plan, get behind it, because it doesn't just sit in HR, does it? It's for all of us to
specifically answer the question, it's 30% completion in exit interview questionnaires that we send out.
Yeah. So not great.
No, it's not great.
But there'll be some really good learning from that one.
I think the problem might lie, Jeremy, in exit interview questionnaire. We need to be having a system where we sit down our staff face to face and have a conversation with them about, how was it for you? What would have made it better, and what could we change that would have caused you to stay rather than leave?
And as well as that, we need to focus our efforts on keeping people before they decide to leave.
Stay interviews.
And with constrained resources, I would much rather do that than run exit interviews. So, for example, the monthly check-ins we now do for people once they've joined us after 3 months. So I've hosted 2 of those since I've joined. That brings new joiners together to hear back from them about what's working and what's not, so that we can act to keep them before we lose them.
Yeah, no, it's a really good challenge back to me, actually. I appreciate that, thank you. Because you're right, we need to be causing people to stay, not kind of slamming the horse.
Yeah.
The what is it? What's the expression?
door
We
after
slam the door after the
the-
horse is
the
bolted.
horse
Not
is
we don't slam the horse.
Yes.
Tricia and then Paul.
Paul, did you want to come in first on that particular point?
Yeah, thank you. I think it's just a comment. I guess needs to be put in the context of the wider labour market, because we draw these people, I guess, from local communities. So we also need to understand that. I think there's something about how we bring people in the first place in terms of setting up expectations when we're in the recruitment process, because I think that then very quickly follows through into what people expect when they arrive, but also what the roles look like and how they expect to discharge those roles. So I think healthcare settings are very different from other settings. And if you come into those settings thinking that you're going to be able to operate in a way that you've operated maybe in other organisations or other settings, then you can very rapidly become disenchanted, I think, and decide that you're going to move somewhere else. So I think understanding where people are coming from also, and how we're setting up expectations may be a way of reducing turnover in the longer run.
Yeah, absolutely, and really pleased to hear, Jeremy, about these bringing new joiners together and periodically, so that we can encourage them to stay is great. Thank you for that. I'm going to go Trish and then MC.
Sorry, Chair, I overtook you and asked to bring Paul in first, so apologies for that. This isn't a new problem. This 2-year thing, this has been running for 5 years, and we ran Proud to be Admin as an initiative to get people to say, I mean, the numbers have dropped, the percentage hasn't dropped, but the numbers have dropped. I don't know whether that makes any sense or not, but it is a long-standing problem, and we've had stay conversations and exit interviews, and we don't seem to be able to really crack the issue, whereas we have done on other turnover. That just on that point, on the overall IQPR, I mean, I just want to say, Stuart, this is an iterative process, but I can see the improvements in the IQPR month on month. Every time it comes to board, it's improved. But one of the things we had, and it's on the agenda today, and so we raised as part of her big ticket item, is the race equity plan, and we had the draft at People and Culture. We need targets, metrics and everything. We have got the metrics, but I wonder if they should be integrated into the IQPR, so we hold ourselves to account in one place for that. And not at People and Culture, but it's not the remit of People and Culture, it's the same issue around the targets for carers data, whether that should be rolled into the IQPR, and then we don't lose sight of it, it's all in one place. Other than that, from committee, we agreed with listening to action that there were too many programmes running, 24 pioneer teams in wave 2, and we supported the idea that that might be reduced in wave 3. We also had the corporate redesign, which is again on the agenda as well, and the need for understanding the uncertainty at this time and how we communicate. We also, this was Paul, I think. Paul thought on staff turnover. It's been consistently well below target. It was a target of 15% for some time. Whether we should reduce that target and keep it sitting up there and patting ourselves on the back and saying, well done, well done, well done. Perhaps we should be reducing that. So that's just a question. And yeah, that's about it.
Right, so Tricia's asked a question there. Jeremy, are you happy to come in there, or would someone else like to have a go?
Yeah, from memory, I think we captured that as an action from PCC, so I definitely support Tricia's view that that should be reviewed and reduced. We'll bring a recommendation forward.
And just on the other, making sure that we're tracking things like the race and the carers, absolutely, that's in the plan that Stuart's already working on with Alan.
And the carers is in there as well.
Yeah.
That's really great. Thank you. Thanks for that report. Last one, Tricia, very much to board. Stuart?
Okay, thank you. I'll bring Jess.
Hang on, I've missed MC, haven't I? Right, sorry, MC, apologies. Sorry, Tricia.
Just a point on these staff leavers. When I did my, and this is anecdotal, but when I did my induction, there was a lot of people in the room that had left us and come back. So I think it is worth capturing the other side of the coin too. And it was really interesting in breaks talking to people about why they'd left and why they'd come back. And sometimes they'd been tempted away by what seemed like a sort of marginal pay increase when actually culturally they found it quite difficult where they went. So I think it would be interesting to see the whole picture if there is a way of us joining up those dots.
Great point, MC. Thank you. Jeremy?
Yeah, thank you. Another example of why there's a lot to get under the skin of, and another example of that is people who leave us to access education and training, who also then come back, and we need to make sure they're not counted in this data because they're leaving for a great reason with our support and hopefully to return.
Really good point. And if we could see that, it would be an absolute hallelujah moment. And I'll ring you up, Tricia, from your beach in the Bahamas or wherever you are. Tell you. Thank you. Great. Okay, back to you, Stuart.
Okay, thanks. Tricia, I think you did give your update there to the Chair's report on
Yeah, I think I did as well, and I'm delighted to be handing over to Paul. Good luck, Paul.
And did we note the... Yeah, okay, good.
You did. Okay, thank you. Bringing in Jason now for improving value, please.
I was getting worried there when you said quality. Obviously we have the finance report, the detailed finance report in the pack. I'm not going to go into the detail, but I am going to pick out two particular issues. So firstly, in terms of our planned position and the achievement of the year-to-date position, it's been achieved by non-recurrent items. And if we continue at the current level of expenditure, we have a risk, and the report mentioned it at 6.1 million. Since the June month end, that has reduced to 3.4 million. However, there's still a significant risk in the financial position. I hear you ask, what are we doing about it? In conjunction with each of the localities, we're developing a financial recovery plan, which is looking at those mitigating items that we can look at for, one, the overspending areas, and two, the under-delivery in the recurrent EVI that Lynn's mentioned in the Performance of Finance Chair's report. That we hope to bring that to exec next week, and then take it through the governance processes to show that we achieve a break-even position for the full year position. However, as we stand today, there's significant risk within that financial position, even though we're achieving the year-to-date position as planned. That was the first item. The second item is about the deficit funding position. So within the plan, we received £6.8 million of deficit funding, and that the assumed receipts within year. That's dependent on the Norfolk and Waveney ICS achieving their financial position. However, as at month 2, they were circa £3 million behind plan, and that's got worse in month 3. Therefore, that creates significant risk in future quarters delivery of that deficit funding. So it's received in quarters. We've had confirmation that quarter 1 will be received. There's currently a process going through for quarter 2, and if there's not a perceived improvement in the system position, it is likely that the deficit funding will be withheld. Within our financial risk that I mentioned in the previous point, we haven't reflected the non-receipt of that deficit funding. And again, linking back to so what do we do about that? We've recently, last week, actually it might have been earlier this week, written to NHS England with regards to that point, and the massive risk that it puts into the trust with regards to our sustainability and the financial sustainability, but also the ability for our recovery journey if we do not receive that financial support. So we haven't had responses yet, and obviously depending on the response we'll bring it back and react depending on what that response says. So they're the two key issues that I wanted to raise from the finance report and open up to questions.
I mean, this is one of our absolute top risks, isn't it? Because we haven't got the money, we can't make the transformation happen. It's as simple as that. And can I just summarise back, Jason, just so we're all clear on this? And this is absolutely respecting the very significant challenge that our provider colleagues across the integrated care system have, that if the overall system is in deficit, we will get the £6 million that we've got as deficit funding taken off us, even if we come in on budget.
So we've had Q1, so that won't be taken off.
All right, so that we've banked that.
Future quarters,
but
yeah.
Future quarters will be taken off
Potential,
us.
yeah, we won't receive it.
Through no fault of our own.
Yeah. So that's why it's imperative that we deliver our financial plan. So we hold up our end of the bargain effectively.
Of course we do.
And then that puts us in a lot stronger position to be challenging back to regional and national teams.
And just remind us all where the system is now and what your professional sort of looking into the crystal ball that we gave you the other day.
I can't give the actual position because it hasn't been through all other boards,
Oh, right.
but I can say it's north of £3 million.
Of
£3 million, and that's for month 3. So if you were to prorata that, it's a £12 million difference deficit. That's a very blunt tool, but there's significant risk there, and things like the industrial action that we've just seen don't help with regards to the improvement in that risk.
So the question is, we've written to NHS England. Caroline and I signed that very helpful letter off to say this isn't a sustainable position for the trust to be in, to suddenly find that we need to find an extra 3, 4, 5 million pounds mid-year will derail our improvement. Is there anything else we should be doing or can do?
Just to remind us that we've already written to our ICB colleagues, who are sympathetic to our position. And we have a meeting coming up, don't we, next week with the ICB and the regional director, so we can address that, I think, as well, Zoe.
And we have the exec to exec with the ICB next week as well, don't we? Yeah. Where this is on the agenda to be discussed.
Oh, good.
Yeah.
Okay, so we're airing the, we're raising a very large red flag that this can't come back to us to have the money taken away from us. But Helen.
Yeah, we also have next week, I think, the NED meeting with NEDs from the NNN. So I think, again, it's another opportunity to raise it with them.
Yeah, very much so. Thanks, Helen. We'll put that on the agenda for the Norfolk and Norwich visit. So the NEDs are, just so the board knows, the NEDs periodically are allowed out and go and talk to other providers. And we've had a series of NED-to-NED visits, which are very, very informative and helpful. So we're going to Norfolk and Norwich, so we'll raise it there. Roger.
It may be worth considering briefing our MPs, because that's another route. It comes with risk, but when you're dealing with an immovable object, you need to go around it.
Yeah, I mean, full disclosure, we have spoken when we were down in Westminster and met a number of our MPs from across both Norfolk and Suffolk. This was an area that we discussed with them in order to flag as a really significant concern for us. Great, okay. Okay, Jason, look, I mean, we know this is a risk. We're really on it, aren't we? I think we feel very, very, very well cited by you and your team on this, and thank you for everything you're doing to try to ensure that what we don't want to happen doesn't happen. Stuart?
Yeah, thanks, Zoe. We've now concluded the IQPR items, but I wanted to bring in Helen for the Mental Health Legislation Committee Chair's report.
Thank you. Just very briefly, colleagues will be aware that this is a committee that's evolving, really. We had a good second meeting, and one of the things that we had was an update on the work that's happening within business intelligence to develop a dashboard that will enable us to do much better reporting back and give board assurance on our position. We've agreed 3 main areas of focus over the next year. One is the data quality. The second is the broad issue of service user engagement, including the delivery of patient rights under Section 132, mental health advocacy, that whole broad area. And then the third is, which we had some discussion about at the meeting, which was the delivery of Section 117 aftercare, which again is not performing as well as it should, and so an issue that we want to do more of a deep dive into. Thanks.
Thank you very much, Helen. All I would say is I'm really glad that we've taken this decision to create the committee as a standalone, and I think we're getting real clarity of the areas that we need to focus on. I think the dashboard's imperative, isn't it? But that's coming, which will give you eyes on in order to be able to do the assurance that you need to do as well. Would anyone like to ask any question of Helen's report? Can we note that as well, please? Stuart?
Just a proposal, Zoe. I didn't know that you wanted to take this side of lunch break, the Audit and Risk Committee Chair's report as well, just to get them all rounded off in one section.
I'd like to do that. Is that okay? Are you all right? Because Lindsay is kindly stepping in for Julian here. Over to you, Lindsay.
Thank you. So on Julian's behalf, who now chairs Audit and Risk Committee, you've got the papers already, so I won't go through every item in here, but a couple just to pick out. So we approved the 25-26 internal audit plan, which is a key part of our assurances that we receive as a board. And we also looked at the responses to recommendations made following the Counter Fraud Authority's visit last November. So we had a very positive visit from the Counter Fraud Authority with some recommendations to look through. And I just want to then bring out a highlight as well, if I can, for the board. The IG team, Information Governance team of NSFT, received an accolade of Information Governance Team of the Year at the National Strategic IG Networks, which is a really good award to receive, and we should please do give our commendations to them. Secondly, and I still don't know what this award is, and I should have asked the question before, but our Information Rights Manager received the Human Encyclopedia finalist. Yeah, she should be on my quiz team as well, which I think is a huge thing. So please, congratulations to those teams. And again, we look through the board assurance framework as we normally do at the Audit and Risk Committee. And as I've already mentioned earlier in this board meeting, good to see some of the improvements that have already happened and plans moving forward. So of what to do with the board assurance framework and risk management next.
Lynn, thank you. Have I got... Yes, Jason, come on in.
Yeah, thank you. Firstly, just on the awards, yeah, we have passed on, or I will pass on the congratulations to the team and to Debbie specifically. Just regarding the Counter Fraud Authority visit, that's actually led to me being involved with them closely in terms of engagement with the wider NHS in terms of how they engage, but also setting up networks with regards to specific sectors, i.e. the mental health sector as well. But also the Counter Fraud Authority have released new guidance about the offence or failure to prevent fraud for organisations, and we're discussing that in detail at next week's Trust Management team. So there's a change in legislation as to the responsibilities for organisations about preventing fraud.
That sounds like it will make its way through to board at some point, Jason, if we could. Yeah, great. Okay, thanks very much indeed for that. Ade.
Just on the internal audit plan for 25-26, one of the other things that we agreed, and this was mainly a request from Julian, was to add some flexibility in the plan so that we can capture some of those. We can do some update work on some of those areas from the 24-25 plan where we scored limited assurance. So just so that we can go back to those areas to make sure that we've made the improvements that we need to going forward.
That sounds eminently sensible. Thanks for that explanation. Any other comments? So we'll note the congratulations to the team and to Debbie. And thank you very much, Linz, for stepping in for Julian so effectively. You'd think you'd have done it before. Okay, we've got a batch of reports which I've found fascinating to read, and I'd like to say a thank you. I think was it Anya pulled some of the reports together, which are the annual reports of the chairs of committee, which outline and set out all of the extensive work that the committees have covered and the areas that they've drawn attention to. And what they're following through on. So I thought having all of that in one place was terrific. So thank you to the chairs and to the team concerned. I think these are simply for noting because they don't give rise to further issues for discussion. But I do have a question. I think there's such rich material in here. I wondered how we could maybe put it into something that's a little bit more accessible, so we could have this as maybe information going out to our Council of Governors, but also, you know, a broader reminder across the organisation of the way that our governance works and the types of issues that our committees are maintaining sight on. I'll look to you, Rebecca. You don't need to come back in the moment, but is that something perhaps we would be sensible to take forward?
Yeah, definitely.
Okay.
Yes, absolutely, Chair. I'll work with Adi on it.
I just want to ask if any of the committee chairs have got anything, having gone to the trouble of producing these reports, these annual chairs reports. Oh, I just want to check with our chairs if they have anything particular they'd like to highlight from theirs. No, could we note all of those reports, please? Great. Adi.
So just another thing that I think we can do slightly differently in order to add to the richness. So separately, at the moment, separately to those reports, we also do questionnaires that go out to all the attendees, and that forms another report around the effectiveness of the committees, you know. So what I'm planning to do going forward is actually to join the two together so that the annual report from each of the committees will be both a report on the things they've done, but also on how people have perceived their effect, members and attendees have perceived their effectiveness, so that that's essentially one report that reports on all of their work.
Right,
so that will be the position for next year.
Okay, thank you. Well, that sounds very interesting. Thank you very much for clarifying that, Ade. Great. So we've noted all of the chair's annual reports, and I think that's now lunch, isn't it? Look at the timing. 12:15. You'd like to think someone's chairing this rather well. Right, lunch break for 30 minutes. Great, thanks very much. Very good. So, okay. So the next item on the agenda is the proposed changes to the Trust Constitution. We need to approve the changes, and they relate specifically to ensuring that our Council of Governors are reconstituted to face into our localities for numerous benefits that the report sets out. It's been through a lot of consultation, with thanks in particular to Paul, with our Council of Governors, and through various workshops, a few meetings of the Council of Governors, and it's been approved because what it will enable is our governors to have a real affinity to place, just in the same way as us as directors, executives and non-executive directors are also moving to have that place facing, locality facing role as well. So that's the kind of the sort of the broad overview of the reasons why we sought the changes, and this needs to be approved through board. So unless you want to add anything, Ade, I'm very happy
you've done a really good job.
to put it to the board that we approve the changes to the Constitution, unless anyone's got any questions. No. Okay, so we are asked to approve the changes, noting the 3-year transition plan, and also not to seek an interim governor to fill the vacant Norfolk public governor role that expires in January 2027. But that's also converted into a place-based role and put out for election. Is everyone happy with those amendments to the Constitution? Thank you very much. Let's move on to the improving health section of our agenda. I'm pleased that we're going to now have a discussion on the crisis team and section 111 service update, which we've heard a lot about already, but this is a really important item for us in terms of trust priorities. Over to you, Stuart.
Yeah, thanks, Chair. So I'll take the slides as read, but I will just pick out some highlights and pick out sort of the what we're doing and what next issues, I think, just so we can have a conversation. So the scope of the work that we're doing around 111 and crisis has been around the crisis resolution home treatment teams across the organisation and the 111 mental health option that we have in the Trust. The aims of the work that we're doing is to deliver improvements to support people when they experience a mental health crisis, whether that be through 111, how they access services, or whether it's the response that we provide through the crisis teams. And also at the same time using our crisis support and our urgent care pathway to reduce the need for inpatient admissions and how we can offer support and help for people closer to home in line with the long-term plan. Work that we've done up to now is we've done a full diagnostic of our crisis teams across all 5 crisis teams. And not surprisingly, we've come across a lot of variation across those teams, and the work that we're doing is to try and reduce that variation. And we've got variation across those teams in a number of areas. So we've got variation in terms of intensity of delivery of service, so how often we get out and see patients, and what we consider to be the amount of times we'll go and see a patient during the day before we were actually considering admission. And I think what we're finding is that we've got quite a low tolerance, so we tend to say that once a day is probably as much as we can do, and then we would have to admit somebody. So we're working with the community, with the crisis teams on that. Variation in activity, about how often we're seeing patients, what type of caseloads we've got across our crisis teams. Variation in resource, so how many staff are in each of the teams with what skills. There's real variation across all teams in that. And variation of the experience our service users and carers are experiencing through sort of being involved with those crisis teams and 111 services. Work that we've done, so the diagnostic is completed, we've looked at that. We're working closely with the Lived Experience Advisory Group. We have a new crisis steering group chaired by the coup to monitor improvements that we're looking at trying to improve all of those things I've just talked about how we increase activity, how we sort of increase intensity levels that we can support, how we've got the right level of resources in those teams, and how we sort of look at the experience of our service users and carers. We've also done a lot of work on the gatekeeping across the organisation, so that we're ensuring that patients are seen face to face by the crisis team before we consider an admission taking place into one of our beds. And we've also developed with the teams the crisis standard operational procedure, and we're embedding that across the crisis teams now. We've pulled together a list of metrics that we're now going to monitor those teams on to ensure that SOP is fully embedded, and we'll also measure the impact and any non-compliance that we might have for those crisis teams as well. In terms of what next, more work to do. Team performance improvements need to happen, and we're trying to work with the teams to measure and understand how they can deliver those and get trajectories improvement for those as well. We are looking at new model developments, things like initial response services across the organisation, things like you've been to see in central and northwest London. And what we're trying to do is develop a new model that's based on population health needs, and so that we've got actually variation, but it's warranted variation based on population health need across those teams. And then we're doing a training analysis. We will have a gap in training, so we're looking at the gap analysis that we'll have for training. This is where we are now, this is where we need to be. What skills do we need in those teams in order to deliver what we need to deliver moving forward? So that's the crisis element of it. On 111, we've done a detailed diagnostic of the 111 services across both Norfolk and Suffolk. And I think I said it earlier, but not surprisingly, capacity didn't meet demand a lot of the time. Didn't have enough staff in the teams with the right skills to be able to take the calls when they were needed. We had that issue, which is the one I highlighted earlier, around peak times, and we were actually moving from one shift to another, so nobody answering the calls during the peak times. So we've put something in place to sort that straight away. We've also identified a number of high-intensity users, so a number of people who make a lot of calls into the 111 service. And we've identified those service users and carers and looked at different ways of being able to support them. Is there something we need to do with those particular patients to support them more? And we're also working through how the 111 service works a lot closer to the crisis teams. So it can support, the crisis teams can support the work in 111 and vice versa. Still more work to do to reduce abandoned calls and answer calls in a timely way. But we're working through that to make sure we've got the right level of resource in those teams. And we've got the right skills in those teams to be able to answer the calls. So that when we hand off to clinical staff, because it's a clinical call, that we've got the right level of skills in those teams as well. What next in terms of 111? We're bringing the North and Suffolk services closer together, both operationally and clinically, with a potential move to have one service across both Norfolk and Suffolk. Removal of variation, so we're really trying to strip out the variation. We have variation between Norfolk and Suffolk teams, working slightly differently. And Suffolk will now be triaging very urgent calls in line with what the way Norfolk work. So the two teams will be operating exactly the same. And we're in the process of agreeing a new workforce model across the 111 teams to try and improve the service across the board. Other stuff that's in progress, like I said, we're working towards an all-age crisis service, but we need to just agree that model and what that looks like. We're also really interested in developing an initial response service across our services to cover both Norfolk and Suffolk. We're working to develop a trusted assessment. At this moment in time, we've got that agreement that we no longer admit directly from psychiatric liaison services, and everyone will be seen face-to-face by the crisis team prior to an admission. But over time, we would like the psychiatric liaison service to be able to directly admit the beds. But, you know, they've done the work that we expect them to do, and that assessment's agreed, working with the crisis team and the psychiatric liaison team together. We are looking at AI and digital innovations, you know, the ideas that the service user came up with this morning around being able to do a video call. We're looking at that and how we can sort of free up the time that our crisis team spend right into the APR and things like that. And how can we use AI to develop that and look at that in a lot sort of from a productivity angle. And then we're also looking at crisis and urgent assessment centres. There's some really good examples across the country about what that could look like and what we would need for Norfolk and Suffolk. So we're working through that as well. So that's a really quick update on a massive amount of work that's happening across this particular area, across the Trust. Happy to take any questions, Zoe.
That's really great, Stuart. Thank you. And just a comment, really. You didn't say it yourself, but this work is really moving forwards at pace, which I think is really commendable as well. But questions, observations, David, and then Kath.
Yeah, really pleased to see this. Really, it's long overdue. I think you recognise. I think when we saw the initial analysis a few months ago, some of us thought we might be able to move even quicker. But seeing this and all the steps that you need to undertake, I'm sort of comfortable with the timeline. But as Zoe says, it is moving at pace. And whilst you've clearly got a steering group involved, it's a real challenge to traditional working practices. So I want to get under the skin a bit about how staff are buying into this or not, because it is a massive cultural change for them on both elements of that service. So any sort of early observations on buying?
So culture is an issue. So, we need to involve the staff in the work that we're doing. So we've had a number of workshops now, David, where we've pulled staff into those workshops and talked through the issues and problems, and, a lot of the time held a mirror up to the service and how it's currently operating, but actually working with staff, service users, carers and families, and trying to understand how we can improve that service. What does that look like? What will good look like to them, and how could we improve this service? So that with those workshops of the staff feel a sense of ownership, which is really key in this. They feel that they're part of the solution. They've actually worked with the team from transformation in coming up with the solutions to pull together what this will look like in the future. So I think that's where we get the buy-in and change the culture as well.
Thanks, David. Kath.
Thank you. This is really positive, Stuart, the progress that's being made, or recognising the big journey that we're on. I think it's a challenge to ourselves about the voice of people with lived experience, and how strong, is it sufficiently strong across both parts of the pathway. We make reference to the lived experience advisory group within the crisis improvement programme, but not necessarily in 111. And I think the other question, I think, is, do we have the voice of carers sufficiently in both of these pathways? Anecdotal feedback is sometimes people are not listened to if they're the carer of someone who is ringing 111. And actually we just need to make sure that the service meets the needs of both people with service users but their carers as well. Thank you.
Good challenge, Kath. Thank you very much. Stuart?
So service users and carers at the heart of what we're trying to do here. We couldn't do it without them. Do we do it enough? Probably not. Are we trying to? Absolutely. And anybody who sort of has got, somewhere to point me where we can pull in more sort of experience of service users and carers, I'm more than happy to have those conversations. The more the better, Kath. Anything we can do to involve them. It's really about involvement, sitting shoulder to shoulder with the people who need to use these services and design it together.
Great. Well, thank you. That's an action, isn't it, for you to talk to one another, and thank you, Kath, for raising that really important point. Anthony.
Thank you. Great piece of work, Stuart, and long overdue. Can I just check, in terms of the steering group, do we have colleagues from police and primary care involved? It's probably just not that visible in the presentation, and it's such important stakeholders in this.
Yes, we do. We've got local authority, police, acute trusts involved in that. All our partner organisations are involved. Third sector are involved as well. Everyone's round the table.
Good point, Anthony. Thank you. Linz and then Jason.
Thank you. Just thinking about the timelines that we've got within here, so we're hoping to have this by October. But there's still quite a lot of other areas that you talked about, really great areas to come in, like the use of AI and supporting our staff to be as efficient as possible. How is that aligned to the timeline that we have within here?
Yeah, there's more work to do on the AI. That's probably a longer term piece of work. We'll try and, we're looking now at what other organisations are using around AI and digital, and whatever we can do quickly we will. but there's probably more longer term and medium term work that we need to do to understand how digital can support that.
Okay, so sorry, just a follow-on question. So October 25, what does success look like for that?
I think it's a far improved service, that's delivering a much more responsive response to service users and carers and families, with the staff with the right skills in the right place at the right time. I think the work that we need to do on digital will come a little bit further down the line.
Okay, be interested to see if you can quantify what success looks like at a later date.
Happy to.
Can I just follow on that, because it sort of chimes with the thought that I was having. Obviously, Caroline, I heard her say, you know, basically we're going to have a standard offer across the whole of Norfolk and Suffolk. So irrespective of where you live, you're not going to have a postcode lottery, which is what probably we have at the moment. I think from a board perspective, certainly my understanding as a non-practitioner, actually having a session separate from board where you can walk us through what a great crisis response, 111 response looks like would be really, really valuable if we could program that in. And I'd also like to understand, you know, this is a service that we ought to be able to replicate from other places. So beg, steal or borrow, places that have got this really good and in place. And so again, I wondered what we've done in that regard, and I know Andy's got the answer to this because I remember you talking to me about it earlier, but it wasn't a leading question because I sort of not remembered that. But what are we doing to make sure that we're going to make a step change transformation rather than just edge things forward a little bit? And I'll come to Andy after that, okay. Stuart. Go on.
So I'm more than happy to just explain some of that. So we are trying to get more people from our organisation out to see other services and what's on offer and which way other organisations in the country do that. I bring quite a lot of experience in this particular area from sort of my previous organisations and organisations I've supported to develop things like IRS services across the country. I think we've been really insular as an organisation for years now, and I think it's a time now to get out and see what good potentially looks like. So we are getting stuff out, and it's not just about getting the transformation team out there, it's about getting the stuff on the ground out there to understand what good looks like, and we're starting to do that now. So Andy's been up to Lincolnshire, and we've got plans in place to visit CNWL, we've got to visit up to Lancashire, we've got to visit up to Combined, and we're also looking at CNTW as well.
Fantastic. And if I may suggest, and I'm guilty of not doing this when I went to CNLW myself, but if we could put around the board the fact that these visits are happening, not to kind of change the intention of the execs and so on, but I suspect NEDs, if they were available, might really value joining one or two of these visits to other places, because it really is a great way to learn. Andy, did you want to come in?
I'm probably just going to add to what Stuart's saying, really. I think it's so important around the culture around this and getting outside of NSFT. And I think part of when we were talking about lived experience and the service user story, but also the culture of the staff, we're not only going out, what we're trying to do is arrange at the moment a couple of specific workshops for all of our staff who are working in those crisis pathways at sort of band 6 and above, where we're asking for that to open with lived experience stories at the beginning, so that we really understand and reflect a bit more about what it feels like to go through the crisis pathway here, but also bringing partners from CNTW, from Lincolnshire, from Leicestershire, hopefully into the space to come and talk with our staff, to help our staff to understand and have think about what good looks like in other organisations, and then giving them an opportunity to reflect and turn that into what does NSFT good look like, and how do they turn that into. And some of that really is around just giving them the opportunity to think differently. It's not about necessarily resource or changes, it's about making them think different about, referring to the story earlier, we heard if somebody's on 111, why can't we just ask them to come and see us at the base at the crisis team? It doesn't need a whole new space. It's about shifting that culture.
Yeah, absolutely. Did you want to come back in on that point, Stuart?
Well, it's around the visits. Because I think it's really important around the visits that Yeah. The problem that we're trying to solve and the service that we're trying to deliver isn't an NSFT service, it's a system service that we're trying to develop. So it's key that when we go and visit that we take the right people with us. So, you know, I've hosted visits a lot of times in my previous trust, and I always used to say, bring commissioners with you, you know, bring partner organisations with you, you know, because you need to develop it and deliver it as a system. So it's making sure that we've got the right people on those visits as well from the wider system.
Good point. I'm going to bring Caroline in. I know, Jason, you're waiting, but I think Caroline wanted to come in on...
Oh, sorry,
no,
Jason.
No,
could have
go
waited
ahead.
after you. I guess I'm just completely concur and support that we're looking outwards right across a whole range of pathways, which is so important. Just coming back to Lindsay's point, really, around what does success look like, what does good look like, and us being clear around what are we focusing on. So radically, you know, not having X percentage of drop calls, people being able to access support, what percentage in 4 hours, in 24 hours, productivity levels that we want to see, vacancy levels. I wonder, Stuart, if we could take that, given the timescale where we're saying October is going to be the time when we're going to be up and running, I wonder if the next cycle of committees can take the what does good look like into the Performance and Finance Committee or Quality Committee, whichever committee it is that's overseeing the development of this. Then we're clear what does it look like, and people can contribute and debate and contribute to that. If at all possible, that would be brilliant. Thank you.
Is that doable, Stuart? Yeah. Lovely. We'll note that as an action from this discussion then, that will be the description of the quality of service that we expect for crisis and 111 will go through the board committees, obviously through the governance in the exec prior to that, and a series of measures that will enable us to track progress. Great. Even a trajectory or two. Good, thank you. Jason.
Thank you. I think we all realise how important this work is, especially following the service user experience that we heard earlier. Mine's a bit of a point of clarity. On the work in progress side, it talks about a single point of access for everyone. Linz and I had a visit last week with the North Norfolk and Norwich adult single point of access, which doesn't sound like a single point of access. It sounds quite specific to a service. And I just wondered, is the work you're doing here linked in with other single points of access across the organisation? And is it really a single point of access, or is it multiple points of access?
I think it needs to move towards an absolute single point of access for mental health support across the organisation. But it'll take a little time to try and map all of that. And, you know, we will have multiple points across the organisation now. You know, you can refer to CMHTs. So, you know, what are we doing? We're pulling CMHTs into a single point of access. It's all the conversations that we're having at the moment around what the model needs to look like.
Thank you.
Great, thanks, Stuart. Jeremy?
Yes, Stuart, picking up on the references to workforce models in the slide deck, and just wondering how you see the extent of change there. Is it significant or less so? And what's the balance of sort of risk versus opportunity there? And how can me and my team support?
Yeah. So there's work we need to do to just sort of map that. It's in progress now in terms of what the skills and what the sort of resource would be to deliver the services we need to deliver. Once we've got that identified, there's probably a bit of work to understand how we get there in terms of time and training. I think that's the main areas. I think until we've done that bit of work, I won't have the numbers. And then the skills gap, we'll need to understand what that looks like in terms of time as well.
Stuart, can you help, perhaps at a future session, us just make sure that we are reflecting the kind of rural nature of Norfolk and Suffolk? So absolutely not against us pooling 111 resource, but if you think about Stephen's, you know, story this morning and previous patients that we've heard from in other board sessions. It can be really frustrating if you're in crisis and you're on a call and you're told just pop into a hub and that hub's 25 miles away and there's 2 buses a day and you can't afford one of them. So there is some kind of nuances around the area in which we cover, and just make sure that we're kind of really sensitive to that and understanding the kind of the context of that for Norfolk and Suffolk.
Yeah, more than happy to. I think well, let's use that walkthrough session to just talk that through. I think it would be, we are on that. It needs to fit the population needs of Norfolk and Suffolk in all areas. So there's a number of examples across the country where they use some quite novel approaches for people to access services. More than happy to walk through that at that sort of session that we have.
Okay, great, thank you. So we're going to have a walkthrough session so we can have that discussion as a board and a briefing on what good looks like, and then the measures will be brought through the appropriate governance and committees in the October round. And just to say, I thought it was a really fascinating update. Thank you, Stuart. I've deliberately allowed this to go on longer than was advertised on the agenda. I think just note to self, really, when we identify the big ticket items for our agenda, Caroline and I are having a kind of catch up after every board now. I think we just need to make sure that we've got the right time allocated to those big ticket items as well, and we all go in with that kind of shared understanding. But that's been a great discussion. Thank you very much indeed, Stuart, for leading us through that. So we note the crisis improvement programme and update with the additional observations we've made. Everyone happy with that? Great. Shall we go on to the annual learning from deaths report, and I'm handing over to Anthony.
Thank you, Chair. So this is the annual learning from deaths report covering 24-25. I'll take the report as read, and can I also take the niche report as read, which accompanies this one and is referred to in the annual report. This has been a significant piece of work for the Trust over the past 12 months, hugely important in terms of our integrity and our duty to service users and carers. As it's evolved, it's become a really innovative piece of work and an exemplar into the system as well, in terms of how we've managed to improve our reporting on deaths, how we're looking at reviewing our deaths, and how we're identifying the learning from our deaths. And all of that has been subject to an independent review by niche independent consultants as well. I think people are probably familiar with the 3 categories that get looked at: expected, natural, unexpected, unnatural, and then the and it's gone from my screen at the moment, but
unexpected.
Yes, thank you, Caroline. So over the course of the year, there was 2,036 deaths, and of those, 6% were unexpected, unnatural deaths. And whilst there's no in the system no direct sort of benchmarking measure, we're broadly in line with unexpected, unnatural deaths as far as we can establish those numbers across the system. I think one of the other areas that has been really important over the 12-month period is the learning and improvement group that was set up, the action plan group around learning from deaths, and that's now evolved into our learning from events group, which has got carers' involvement in that group, and it's where we take through the learning that we extract from the investigations that we undertake. All of that's been a really key development, and the systems that we've put in place are now, I think, an exemplar within the system, and it's hugely huge thanks to Gary O'Hare and the mortality team and the Jason's digital team as well for the work that they've done on this. Niche looked at 3 questions. Is our system for gathering and analysing the data robust and good enough? Does the current data quality meet the expected standards? And how could the board improve on its data, its mortality data? And you'll see from the report that they gave a very positive response, but they've also made some recommendations that they're recommending that we take forward, and we're proposing that the board supports those recommendations. So the board's asked to note the report and the niche report and to support the recommendations.
That's an excellent summary, Anthony, if I may say so. It's a really brilliant piece of work, this has to be said, doesn't it? I mean, I think Roger's comments from having seen this from the Quality Committee said it all, really, but this is a really important piece of work when we think back to where we were 18 months ago. This is an absolute transformation. I should say as well that we must talk about learning from deaths, and we do so with reference to data, but we always remember, don't we, that behind every number is a person and a family and a loss, and we're deeply sorry for that. I'll just open it up to any further comments and observations. Caroline.
Just completely concur, and a massive thank you to everybody who's worked so diligently to get us to this place, and it's a really great place to be, that we've got assurance and credible data. The next really big area is what are we doing to learn and improve. And maybe you could just mention, tell us a little bit about, we've commissioned Niche to work with us to help us to focus on that, haven't we, Anthony? And when are we likely, what's the timescale for that, and what's the next steps of when we're starting to see more rigour around the improvement?
So yes, we've Gary and I are planning to meet with Niche. We're looking at the using our PSERF framework, and we've got people will be familiar. Sorry, the Patient Safety Incident Reporting Framework, the PSERF framework. So that is the framework within the Trust which we'll take through all of our incidents, deaths, the learning that comes out of all of those investigations. And we've got our learning from an improving group now, learning from those events. So Niche are going to support us over the autumn to test the integrity of that system that we've put in place. And in particular, we're looking at the impact that our actions, where we think we've identified learning, where we think we've put actions in place that are going to address things. The gap in terms of our assurance at the moment is that, you know, we've seen those actually being implemented and carried through, and that we can see, you know, the benefits from those actions. So they're going to help us with that sort of closing the circle on the learning to make sure that it gets embedded in practice.
Great, thank you very much. I've got Jason, then Roger.
Thank you. My point's about the ethnicity data and how we learn about just general recording within our services, because the second highest category is not stated or unknown, and if that's the second highest category, it makes it really difficult to look into health inequalities data. So we need to really improve that across the organisation, not only for deaths but for all service user ethnicity data, to help us with that health inequalities work and the learning that we can get out of that.
Yeah, it's a really, really good and important point. Thank you, Jason. So that will be picked up, Anthony, by the work programme. It's part of it, is it? Lovely. Okay, great. Kath?
Yeah, thank you. I was going to pick up on the ethnicity reporting as well. It features as a key improvement priority within our patient care race equality framework plan, and very explicitly within the draft health equity strategy that Caroline referred to in her chief executive report. So it's just not acceptable. Now, I think I also concur with you, Jason, about the fact that this is not just a single metric that we're not very good at reporting. I think there's a data quality requirement that we need to focus on, for which this is one of them. However, if we're looking at health inequalities, and what I was going to make reference to is also that rich information about other causes of death, the natural expected and unnatural expected, and the work that we really need to do on understanding and tackling other causes of death, such as respiratory disease, cardiovascular disease, etc. So it's remembering all of the individuals that have died over the last 12 months that are reflected in this report, and making sure that we work in partnership with our systems, and our strategy is going to be a key element of that, on how we learn and improve with regard to the reasons why people with adverse mental health and learning disabilities are dying earlier than they would have if they didn't have serious mental illness or a learning disability. Thank you.
I mean, at the heart of this, it goes back to this whole issue that we pick up when we do listening into action and our various conferences. It's about accountability. I mean, why are we not recording race, ethnicity data on it's a critical factor in providing healthcare for our service users, and I think we have to really push ourselves on this to get this right, and kind of set the standards. There is an expectation that carers information, that information on somebody's race, their phone numbers are all correctly recorded, because if we can't have that, how on earth are we going to ever provide great care? So, I mean, that's an ongoing conversation, but it'd be helpful to hear, what are we actually going to do about this? And maybe that's a broader conversation that we take forwards. Okay. I have got Roger next.
Thanks. I just reiterate what wonderful work this is, but we need to be a little bit cautious that we don't make this about perfection in data collection. It's got to mean something. So the next step is going to be the hardest and most important step, and that is identifying what interventions we need to make to who, and measuring the impact of those interventions. And I think that's where our focus should be 95% on, and we can fiddle with various components of the data set, but we're talking about population health largely, accepting that, as you said, Zoe, each case is a tragedy, but we have to use population techniques to improve that. So I don't know how we can do it, but it's got to be done. That it needs to be what good looks like. The second thing is that there is an opportunity within the trust that's underutilised, and that's our research team. And what I think would be a good place for the trust would be to commission its own research and say, ask a research question, hand it over to them. Inevitably, that might mean funding it, but I think that we've got a great team, and we need to get them to work aligned with our really important goals of dealing with those health inequalities.
Yes, Anthony.
Just thank you. And it's just to say that agree, Roger, that that's the key to this, is measuring the impact. And I've already done a literature search on how you measure the impact from serious incidents such as this, and there's not a lot in the literature at the moment. So tapping into our own R&D function within the trust will be a good thing for us to do, and I've been having discussions with the Safer Care team around how we measure the impact as we move forward, but I'll bring that through to a further board meeting for an assurance update.
I mean, it's interesting, isn't it? We've got the annual report on our research and development team, which is a stunning, kind of an eye-opening report, which we probably won't give proper airtime to today, but it's we've all read it, and you know that they could really be a massive asset to us. I was encouraged, Anthony. I had similar thoughts to others. I think we've done brilliant work to get the process right, and we've really focused on that. Section 10 begins to start talking about the so what. What are we doing? What are we learning? What's going to change? But I still think there's a degree of ambiguity around what our ambition is, and how we stop people with a serious mental illness in Norfolk and Suffolk dying on average 16 years younger than the resident population, and that has to be the core question that we keep coming back to, doesn't it? And I think we've all kind of intimated that through the discussions, and that seems to be the next stage of this work, through also niche providing us assistance. Okay, well, we understand all of that. Any more questions? No? Okay, so Anthony, thanks again. Could we review the information and updates provided in the report? Well, we've done that. And can we note the report, and can we approve I think you called them recommendations, didn't you? Can we approve the recommendations outlined in the niche report? And can we also, as a board, thank all of the teams that have been involved in this excellent piece of work, and look forward to receiving regular updates. This is not going off our agenda. It's not like, okay, well, we've sorted the data out. We don't need to worry about this anymore. This must stay on as one of our kind of key big ticket items. So thanks very much for that. Great.
Sorry, did you miss the finance update, or did you?
No, we rolled it in.
We rolled it in, okay.
Yeah. Yeah, I think so.
We did.
It made me worry now. I think we did.
Did.
Okay, great. Thanks. Let's move on to the improving the recording of carers. Safer staffing. Sorry, I've lost my thread. Let's go on to safer staffing now.
Thank you, Chair. And I'll take the report as read, and just a few things to highlight from the report, Chair. The report obviously provides the data for April and May in terms of our position against our established staffing levels. And people will see from the report that and it's been referred to in earlier conversations today, just about the intense pressure that there is on services. So we are seeing a lot of use of temporary staff still at the moment to provide support to the wards. But in terms of safely managing our wards, they continue to be reviewed through the daily staffing huddles, morning and afternoon, to ensure that we meet our safe staffing levels on the ward. You'll see in the report, and the board has been updated on this issue previously, about the registered nurse adult issue that arose in March. We've continued to progress that work. We've now completed the competency assessments for all of the staff that were affected. We've looked at the options for those staff to continue to be part of the skill mix in our teams, and we're moving now towards confirming their positions within the teams. We've provided ongoing support to those nurses as well, and we've identified those registered nurses who are eligible to do additional training to take them up to, or rather being registered as a mental health nurse. So that work will conclude by the end of this month. We're on the 31st today, so we're going to be writing out to colleagues next week, just confirming the outcome of that process. I think importantly, from a patient safety point of view, we've done a significant piece of work reviewing incidents, and we've reviewed over 5,000 incidents across a range of kind of incidents to identify if there were any harms that occurred to patients as a result of the situation that we found back in March. We've not identified any significant concerns from that. So there's nothing that has come out of the data. There's nothing in terms of erroneous use of the Mental Health Act from our findings. There's nothing that's emerged through freedom to speak up or complaints that suggests we missed something with this. And we've presented those findings to the extraordinary subgroup of the Quality Committee. We presented those on the 18th of July. We have been asked to look at the timeline for the employment of our RNAs in the organisation, which we've done, and we've identified some hotspots. So we've given an undertaking to look at some more incidence data from those particular peak times, which we're doing, and we will then present the findings of those to the extraordinary subgroup as well. That subgroup comprises of ICB colleagues, CQC, Health Watch, and obviously our own internal staff, and Helen, one of our non-executive directors. So that's where we're up to with the registered nurse adults in the inpatient services, and we're now, as phase 2 of this work, to satisfy ourselves that our staff have got the right skills and competencies across our services. We're going to do a competency assessment review of our community teams, which commences in August, and we'll have that completed by September. I had my latest webinar event on Tuesday of this week with staff. It was attended by over 100 staff to provide them with an update on the work that's been done to date, and informing them about the next steps. So I think they're the key points that I'd like to highlight, and I'm happy to take questions.
Yes, well done, Anthony. There's been so much work undertaken on this, and beginning to see this now coming through in this report. Helen, and then Linz.
Yeah, I just wanted to add to Anthony's report from the extraordinary subgroup that I think this has been a really very rigorous piece of work and a really thorough review looking back, and from what we've seen so far can see no evidence of any harms arising from the situation. So, but I think we were surprised perhaps that there perhaps wasn't more challenge, but I think that it reflected that it was very thorough what has been done. And I think at the moment, just because I think of diary clashes, Health Watch colleagues and maybe other service user representatives haven't been able to be fully involved, so we just need to think about how they get brought in to be brought fully up to speed on that. But it is a really thorough piece of work.
I think that's really important. It's also really important for our governors, who have a responsibility to hold us as non-execs to account, that there's a thorough and full briefing provided to our Council of Governors as well. Now we're sort of beginning to really understand exactly what the position is. Linz?
Thank you. Thank you for the report, really comprehensive. And also pleased about the harm review as well for the registered mental nurse issue. Along with that and along with the briefing, I would really be keen to see the root cause, the how is this allowed to happen in the first place. It's good that we're taking steps to prevent it now, but we also want to make sure it doesn't reoccur again in the future. And there's a future that at some point we won't be sitting around the table, other people will. So we want our controls to be in place and sustainable to ensure it doesn't happen again. And the second point I want to make, and I feel slightly rude when I say this, but when I read the report, I did think, oh, I've read this before. But actually it is a genuine point. So we've got quite a few things in here that we have read board on board around the amount of commissioning we need for our staff. Issues with sick leave, which we've talked about in the IQPR, whether or not we're using standard clinical work across each of our shifts, and that causes our variations in the staffing models. So what happens next? So when do we draw conclusions on these and fix some of the underlying problems?
Thank you, Linz. And just on your first point about the controls, then I have been working with Jeremy's team around our recruitment controls and our requirements in terms of what our expected standards are for people being appointed into certain roles within the organisation. And we've reviewed job descriptions, ways in which we advertise and roles within the organisation, just to make sure that those controls are tight. We're going to also set that out in a clear policy document as well, but that hasn't been completed as yet. But we've put those immediate controls in place to prevent this from happening. I have not been able to identify anything that gave instructions that this was okay in the organisation. It feels like it's something that evolved, but we've certainly tightened up our processes now to prevent it. So that's where we are on that point. The second point, the approach to safe staffing in the organisation has been a very siloed one, and it's just essentially looked at numbers of nurse staffing on our wards. And I think I've probably mentioned to the board previously that we need to have an enhanced multidisciplinary skill mix on our wards to make them much more therapeutic environments. So our nursing colleagues, our HPs, psychologists, social workers and medics, they've been working together. We've got a workshop coming up on the 14th of August, which is a multi-professional workshop where they're presenting options around revised skill mixes, which hopefully, that will give us a much better kind of therapeutic model offer, and that will address some of the points that often at the moment our staff default to one-to-one observations rather than thinking about what's the therapeutic, and haven't necessarily got the resources to call on for what's an alternative approach here, what's a more therapeutic approach here. So that model will be designed to support that work, and we'll get our standardised processes out of that then, Linz. So the workshop's August. They've been doing the preparation work for that. So by September, I should have proposals for the board around all of that.
Well, it's a great question, Linz, and a good response, Anthony. I think it would be very helpful if we could have a bit of time as a board at one of our development days, maybe just to be walked through what a new model might look like, and just to sort of add to the challenge. It's interesting, isn't it? We focus on our inpatient wards, but we need a similar model that really enables us to have assurance that our community crisis 111 and all the rest of it is also kind of meeting what I would describe as safe staffing levels to enable us to do our job. So understanding how we can put in place that kind of approach, but also be able to track it through our board committees would be really helpful. Thank you. So an action is that we're looking for an update through both board development and then into our committee cycle for the October committee cycle. Is that practical? Yeah, no, lovely. All right, thank you. Caroline?
Just to say a really, really big thank you to you, Anthony, and the team, because you really have worked diligently and at pace and with real rigour. So it's really good to have got to this place and brought partners with you, albeit Helen's important point around service users and carers is one that we need to continue to make better efforts to involve. It would be really good, I think you said that your next report will set out a bit more around the history and the timing when you've completed any review of any incidents, because I think the board need to see that, and then we get assurance as much as possible, how did this happen? And then to set out what controls have been put in place as much as possible, as you set out verbally with Jeremy and the work you're doing together. It's really great to see the work coming forward in terms of skill mix. That's brilliant, well done. And just to Zoe's point around beyond inpatient wards, the workforce skill mix will come in community teams with the transformation work that we're doing. So we'd see that the crisis teams, the work that you're doing, when we see that in October, should have really clearly set out what the workforce skill mix should be, and then that should be mirrored in the community transformation programme and etc., shouldn't it? So it's really integrated.
Yeah, thank you. don't see any other questions. So Anthony, thank you very much indeed for the work that you've done. And can I ask the board to note the report on safer staffing? Thank you. Can we move now on to the improving the recording of carers? Again, one of my top priorities, Kath, no pressure there.
Thank you so much. So, board, to remind people, we heard the experience and personal expertise of being a carer and a service user who was supported by carers when Debbie came to speak to us at the beginning of June. And as a board, we agreed this was a significant priority that required a response, a plan, and then a real rigorous approach to addressing. So the paper sets out, obviously at the moment, our position is not where we expect it to be. I just want to help the board understanding the related person's role and capturing is where the person's name of their maybe next of kin or preferred person to contact and their phone number would be captured, and there is a level of compliance of 62.5% within that, them being recorded in the correct place within the record. And then the additional identification of someone as the main carer, 3.5%. That was July's data. So that's the position we're in, but it is important that we don't interchange the role of the related person and the main carer because they are different and require, to a degree, some very specific actions, whilst the overall improvement it will affect both positively. In terms of it's so important, as we heard, about the voice of carers being listened to, but if our colleagues don't recognise the role of carers, then the chances of their voices being heard and that being contributing to the plan of care and support and keeping our service users safe, then that will be lost and minimised. The paper that you have sets out a plan, both in terms of activities, which are set out in Appendix 1, and a trajectory for both the improvements in the related persons recording and the recording of carers, and that's set out explicitly in Appendix 2. It just is so important that we recognise and we provide that board leadership of why this is so important and ensuring this is happening and the level of activities that are taking place have been included within the narrative within the report and, as I say, the action plan within the appendix. But just to call out a few points within there, we heard from Debbie last board meeting that she's been part of the co-production of the Carers Charter, and the plan is for that Carers Charter to be launched at the AGM in early October. But there's no, we can't just have a charter and expect it to work. There's a whole lot of work underneath that that means that it has traction and impact. But a big part of this is making sure people who are carers actually understand that they are carers. And I would say that there's a big gap in our population of carers that don't necessarily recognise that in themselves, let alone our staff recognising it. So this is working with our carers, not just working with our staff as well. We are going to be launching the Common Sense confidentiality policy, which again recognises the importance of communicating effectively with our carers in order to help people keep people safe. So there is a series of actions set out within the report, which I won't go through line by line because colleagues will have read it. And then finally, the oh my gosh, sorry, I've just had a menopause moment and my brain has gone completely empty. It's building on the listening to action work. We have Think Family and Carers who've been part of Wave 1 and Wave 2, and I feel the feedback that we've received is that they have now got that level of traction that hasn't been in place. And in order to ensure that this is more than a plan and more than words, we mentioned earlier on the IQPR and the Integrated Quality Performance Report and the the reports for each of the localities, where we meet with the localities in the quality performance group meetings, will include these key metrics to ensure that there is grip and oversight and delivery against the improvement trajectory that's set out in the paper. So I will stop there, Chair, and very happy to take any questions or comments.
Okay, thanks very much indeed, Kath. Questions? Helen?
Thank you. I was really pleased to see the report, and really important, I think, that distinction between carers and nearest relative is made, because carers and nearest relative in terms of the Mental Health Act and next of kin may be one and the same, but they may be different, and it's really important that staff understand that. For me, there's a connection with care planning work. It's not just a recording issue. And I think if you've got good quality conversations and therapeutic work, as Anthony was describing, kind of underpinning care planning, then understanding the role of carers and their relationship and the role they play with the patient is really important. So I don't know how we get to the qualitative bit about care planning as well as the numerical bit, but for me there's an important connection there.
Yes, hard to see how you disassociate one from the other, I think is the point, isn't it, Helen? Paul and then Stuart?
Yeah, thank you. Yeah, it's a really good report. I think what I was interested in, the cultural aspects that are raised in terms of professional curiosity, I guess. And you talked about how that might be progressed through learning into action programs. But I wonder if technology might help prompt that. I know there's some references to technology, but I mean, most of us use technology all the time and we fill in particular forms. They won't allow us to move off that form until we've filled in a mandatory field. So I'm just wondering if technology can help us encourage professional curiosity by making sure that that field is actually filled in, and that then prompts the conversations that are required around those issues. So that was my first point, and I guess the second question is whether or not our ambition in terms of the trajectories are sufficient. You know, are those is that the right timescale we should be moving on, or is there a way of expediting that and being more ambitious? Thanks.
Very good point, Paul. Thank you.
Shall I take all the points first and then provide responses? That'd be helpful.
Yeah, and I think Jason just wanted to come in on the tech solution.
Yeah, thank you, Chair. Yeah, so there's various nuances to the technological solution. So yeah, when providing care, sometimes we need to get to certain aspects of a patient record quickly. So we can do reminders, but I think to prevent moving on, that's probably a step too far in terms of the solution. But yeah, absolutely, reminders are something that can be prompted into the system, and in fact we have them in many aspects of the system. I must admit I don't know for certain if there is for main carer, but I certainly know that there are for next of kin.
Okay, thank you. Stuart?
Thanks, Zoe. Paul made one of my points very well. I suppose the other one is just around training, because we've obviously got a bit of a gap at the moment in terms of identification of carers, and I suppose it's how we get, you know, the work that's been done to develop the carers charter, how we get that out there and get that understood by staff, the importance of it, and how we really make a difference to the amount of sort of uptake we get on this. And it's not just the recording, isn't it? It's sort of the conversations that happen once you've identified that carer in terms of where they can get support and where they can get help as well. And having the ability for our staff to be able to relay that information and that message is so important. Thanks, Kath.
Thanks, Stuart. Roger, then Tricia.
Thanks, Chair. I was just going to reiterate the issue of the trajectory, and I'd be a little bit more dogmatic about it. If something needs to be done 100% of the time, then we shouldn't spend 2 years getting there. At the moment, we wouldn't accept not putting the date of birth in the field, or the allergy or whatever, and it should be treated as important. And so well, if it was down to me, I'd be asking for a very accelerated steepening of that trajectory curve.
I might as well come in now because taking Chair's prerogative, sorry, because I think we've got to really up our ambition on this. This is a clear and present danger for us. If we don't put carers' names onto our records, and we need to be able to contact them and involve them in care, then we're culpable in not allowing safe care to happen. And we should be treating this on the industrial scale that we treated learning from deaths. We should be thinking about bringing staff in to go through all of our records, additional staff if necessary, and to be contacting our service users and making sure that information on carers is filled in on every single record of every patient who's under our care at the moment. And we should have a plan to do that within 3 months. That's a random 3 months. That may not be the right number. Not the time that we've got, a year and a half, I think it is, although it's a bit difficult to understand, to get to 80%. I think we just have to challenge ourselves in the board, and you can please disagree with me. The first step to changing the culture is actually having the information on the record, and then there's a fighting chance that carers may be properly involved in care. I feel better for that. Can we just come back on that, Kaz?
Yeah, absolutely. In terms of, so that I got back to the beginning of what I said, there's related persons and then there's carers. The related persons issue is we must have people's contact name and detail and contact numbers in order to be able to contact families as and when that's needed. And I accept the trajectory for that. It needs to be steep. The issue with the recording of carers, which isn't necessarily the same person as the related person, that requires a shift in understanding and of not just the role of carers by our staff, but by our service users and those people who are carers themselves. So some people don't recognise themselves as a main carer. So if, for example, if it was my husband, I would recognise myself as his wife, not as his carer. So there is a change in the understanding, and that forms part of how we're going to do that will be through the Carers Charter. So we can't just tell people they are carers. We've got to get people to understand their role in being a carer and make sure then that information is captured.
Okay, I think you do explain this to us, Kath. I think there's scepticism as to why it's as difficult as it is. I mean, I think we probably just need to take that element of the conversation offline and really be satisfied as a board, and I'm not sure that we are, that it's impossible to disassociate the cultural change and all of the education from the putting the name of the carer on the record. And I think the message perhaps I'm giving and possibly others on the board are giving is we're puzzled as to why it's as complicated as it is. So yeah, I think we probably need to stop that bit of the conversation and seek to better understand what it is you're saying to us in the sense of why it's going to take so long. I don't know whether you want to come in and help, Karen.
Well, what I'd say is what we need to understand is what's the detail of the plan underneath. So is it a matter of, because 100% of people should have their next of kin recorded, but there might only be 20% that have a recognised carer. And you can't necessarily get a recognised carer, I think is what you're saying, by having a phone. If we put an admin team together and said phone every 50,000 patients, that wouldn't necessarily give us the answer. So we're presumably the plan, that's what we need to see, the granularity of the plan, is that we're going to do in a cycle way, when we see people, make sure that's part of the conversation. But then have we got a standing operating procedure that underpins that? Where's the locality buy-in? So I do think we need to see the granularity of the plan that will probably give deeper understanding and a bit more assurance, Karen.
David.
It's okay, most of what I was going to say has been covered, and about this trajectory is just way, way too long for me. I mean, this whole thing about professional curiosity when they see a patient it's this definition of carer. It's about who is the person that supports you, who's the person that looks out for you, you know, and that's the conversation, not who is your carer, so people understand about it. And I think we should be ashamed of ourselves that we've got 3.5% on records. When we raised this some 5 years ago at different iterations of this board, we actually had 4%. And we've been sort of knocking this around the room, and I just think that trajectory is way too long-winded, and there's too much emphasis on getting the carer definition right. That would be my personal opinion.
Thank you, Trish. I think Kath is quite rightly fronting this up, and thank goodness we've got Kath, and I hope you're not taking it, you're getting the brunt of this. We want to encourage this piece of work that's so important to your work programme to move forward, and we would like you to advise us whether you want more resources and prioritisation to be put into this programme so that we can achieve this much more rapidly than the timeframes we're talking about now. But I've got, let me just do another run of hands because I've lost a little bit of track. I know I've got MC, and I've got Roger, and I've got David. And I do apologise if I've got you out of order. I've just, but are you happy to go in that order? Yeah, MC, Roger, and then David. MC.
Thank you. Just to make the point collectively that many of us are motivated to do the roles we do because we have, or we are, carers for people with poor mental health. And I think we have to be unapologetic about pushing hard on this point because it's the reason we do what we do, and it's the reason many of our governors do what they do. But it's not to place that with you, Kath, it's to say collectively we have a responsibility to do this much better. And I think there's a wider point about how we're working as a board. If you take today's agenda, we've been asked to make 2 decisions today. One of them was to approve the minutes, and one of them was to approve the Constitution. Actually, this is an area where if we were asking the board to make a decision, we would be having a slightly different conversation. We wouldn't be making the decision that we would tolerate the level of performance we're describing. And I think there is a wider point around how we try and build in a little bit more decision making at board level so that we can kind of help push on the stuff that is the big ticket items that we described at the beginning.
Yeah, really good point. Thanks, MC. And this is an evolution for our board, and we've talked about that sense that every report really ought to have a recommendation. If it's important enough to come to board, it ought to have a recommendation and options. We spoke about that, didn't we, at the away day, and we do need to rightly be reminded by MC that it would be good to get to that point at relative pace. Thanks, MC. And Roger, and then David.
Just very quickly, I'm just going to offer a potential solution to this, in that we've got 2 issues. There's record collecting and the proportion of our service users who've got an identified carer. At the moment, we've just got an absence of any information. It would not be beyond the wit of mankind to have a field that said, carer's name is this, or there is no carer identified, and you should have 100% of service users having at least that information. Then we could track the proportion of service users who don't have an identified carer and start to make curious inquiries into why that might be the case. And then I could understand that trajectory. But at the moment, we've got a binary problem, which is no record of any description, where one needs to exist. Probably made it more confused.
No, even I followed that one, so I thought it was straightforward. Yeah, I think we need to put some sort of stakes in the ground around this. I think that's the clear message coming out. We'll come back to it, of course, won't we? And we'll have further discussions outside of here. David. And then Linz.
The 2 go hand in hand, don't they? And it's fairly fundamental to me that, it was Helen who said it, and Stuart picked it up as well. What is the care plan? We have the person who's presenting as our customer here, but what's the multidisciplinary team approach to that person in that person's environment? Who's important? Who's helping? Who's supporting? So it is about the care plan. So that for me, often the absence of a carer or the presence of a carer is fundamental to the dynamics within that person's sort of daily living environment. So I think for me it is as much an education training, a professional issue about the significant role that carers play in people's everyday lives. So we need to do both.
I think you're right. Yeah, Linz.
Thank you. Just very briefly, this is an issue that's come out from the Your Data, Your Choices that we've been talking about for over a year. And we have moved from 1% recording to 44% recording, but agree that's not good enough. But I would just like to say thank you, Kath, for taking hold of this issue. And it would be really good to understand next time, not just the trajectories, but also some of the challenges that our staff have, genuine day-to-day challenges. In order to do this, I think it would help us as a board to understand the trajectories more, and some of the actions that need to be taken to tackle an issue that's been really difficult for a really long time. Thank you.
I'm probably going to have the last word on this. No, go on, Caroline.
My only thing we haven't talked about is looking outwards. It feels like it's a wicked issue for us, and can we rapidly, Kath, if we haven't already, through the network of trust that we've got, I think bringing it back into the Quality Committee and here next time, let's see what the trusts do and how they do it, as well as, because clearly people are feeling that they can't agree to this current plan, so we're going to have to do some more work and bring it back. And can we do that as part of it, please? Thank you.
Yes, and no, not at all. And I just think as part of that, I think of a particular case that we all know of. I won't name names in the board that's taking place in public, but I think a dad would have seen himself as next of kin until he knew that if he had been told that his daughter was very, very poorly, and at that point he is clearly her carer and the person that should be absolutely involved in her care. So I think this concept of carer we are overcomplicating. And our starting point ought to be that the person that comes to the appointment or the person that's named as the next of kin is most likely to be the carer. And let's see what other trusts are doing so that we can actually move through this at pace. Okay, Kath, you've taken this really brilliantly, and it's been that sort of difficult, challenging conversation that we do need to have within our board. So thank you, Kath, and you have absolutely all of our confidence that you're the person that's going to make a move on this. There are some actions, so we're not going to approve the plan as presented, just for the record, but you are going to go away and pick up on these points, come back to the Quality Committee, if I may ask, and then back to board. You need to advise on how much time you need to do that, but ideally if you're able to come back to the next Quality Committee in the sort of September cycle and then the October board, great, but you advise us separately from that. So thanks very much indeed.
Gary wants to come in.
Is he popped up?
Gary's back from his
Hello, Gary.
his hospital now.
Right. Oh, I hope you're all right. Right, Gary wants to come in on recording of carers. Okay, come on in, Gary.
Sorry, Chair. Apologies for my lateness to the board, but it was worth going to hospital. I just wanted to pick up on carers and really a couple of points for me. One, this is a real practice issue for the organisation. You referred to learning from deaths earlier, and we had real issues around ethnicity, if you remember, around that. So that's where we need to focus. And I think it's going to be quite difficult for Kath to do this alone. And given the fact it's a practice issue, I think she really needs the support of myself, Anthony, and Faisal to drive this through with clinical teams, and I think we can come back with a much shorter trajectory going forward within 12 months to get there. But we're going to work as a team to drive this through our clinical teams across the organisation.
That's really helpful, Gary. And you know, the learning from deaths model was a model that we see as a model that gets things done, that changes practice. And I think that's kind of almost where we're coming from this, is we need to respond to this at an industrial scale, and I think that's what you're saying as well. So thank you. And I'm sorry I knew you'd popped up, but I didn't quite know why you'd popped up on the screen.
I'm sorry.
No, it's lovely to see you. I'm glad you're doing okay. Great, all right. So shall we move on then? I think I've done the summing up and we've all approved the next steps. Thank you very much, Kath. Shall we move on to Kath? Unfortunately, Talia can't be with us, who's the chair of the Service User and Carer Council. We've got the report. Kath, is there anything else you'd like to add to it?
No, I don't think so. I think the report is clear. This was the last meeting took place on the 17th of July. Really well engaged with, a huge amount of positivity, and we've got a workshop with Rethink, who are our co-production partners, on the 21st of August, where we will be ploughing on with understanding and developing the plans for locality service user and carer councils and how we build co-production capability within the organisation.
Well done, Kath. And it would be really lovely if we could send our best to Talia, and also if we could obviously let her know that we're very keen for her to come back and talk specifically about the Service User and Carer Council when it's appropriate and it feels right for her to do so. So thank you very much indeed for that. Shall we move on to corporate redesign, which is Caroline?
Thank you very much, Chair. And we've talked about this before. As we know, every provider trust in the country is having to reduce their corporate costs by 50% of any growth that happened from 2018-19 up to the end of 25-26. We already had a corporate redesign programme planned as phase 2 after our locality clinical redesign. And of our 18.7 million, that was last year, 18.7 million efficiency programme this year, 6 million is attributable to our corporate services. We've been really leading this at pace because we need to for our own programme and for our improvement of quality aligned with our localities, but also because there's a very tight national expectation of the end of quarter 2 to start implementing during quarter 3. So the presentation sets out, again we've talked about this before, that this is the approach we've taken is to review every single corporate service, apart from the services that went through a redesign as an addendum to the clinical redesign, which is our establishment of our new clinical transformation directorate and the review of our strategy directorate that's now collapsed and has been recreated in the delivery directorate under Tom's new appointment and Stuart for the clinical transformation. We'll discuss this some more in the next part of our agenda in the private board, obviously because of the confidentiality issue around individuals and implications. But we are on track for the phasing of the programme as set out. And we've been working really hard as we can to make sure that we're engaging as proactively as possible with teams that are affected. I think there's just a distinction to make between the number of people that have been part of the review, which is more or less all of our corporate teams, versus those that are going to be subject to change, which is significantly different. But I've been leading communication webinars every couple of weeks. Obviously, each executive director has been responsible for communicating within their own directorates. What's been really positive is the really close working we've had with our staff side colleagues, and through Jeremy and Lisa, they've worked really effectively. And we've had a whole programme of frequently asked questions so that we're making sure that we're giving people as timely information as we can. And there's a whole way of people being able to raise if they're not getting their questions answered, as well as making sure that staff have got the right support. But really happy to take any comments, questions.
Of course, I think we've been kept really well appraised of this as a board through private sessions and development sessions and updates. So this is a fundamental part of our change programme, isn't it?
Yeah.
But we've been briefed at every step of the way. It was interesting, Caroline and I were on a visit was this week, wasn't it? Only this week, to one of our locality directorates, and we were talking about the staff's experience of change when we introduced the localities, and they said it was really painful at the time. It probably took a little bit too long, but now we absolutely see why the change was necessary. And I'm really hoping that the lessons we've drawn from the locality directorates we're applying to this part of the enabling and corporate services redesign, I think, is a fairer way of describing it. So, yes, we're moving at pace, aren't we? And we fully subscribe to that as a board. I don't think we need any further question unless anyone's got a burning question on that, other than to note the pace with which we're progressing, to note that there's further discussion on this matter in board that's held in private, and I'm asking the board to support the changes to the corporate services as set out in overview here. Well done to everyone who's involved in this. Thank you. Right, let's move on now. I see Harpreet's here. Let's see you, Harpreet. Do come up here, join us. This is our report on race equity strategic plan, and I think, Jeremy, it's over to you.
Yes, thank you, Chair. I think I would describe myself as both humble and proud to be presenting this particular item today. Proud of the work of others, not myself, to get us to this point, but also humble, having heard the stories of colleagues across the organisation, and humble at the scale of the challenge that faces all of us as we look to the board to approve this plan today, and to commence the programme of work that is outlined within it. So I'm hugely grateful to Harpreet, who has led the development of this, and to all of you who have participated in our race conference and have actively engaged with our colleagues across the organisation and our staff networks to learn from their experience. I think the two things that are really distinctive about this plan that really help are about the clear accountabilities that are set out in it. There are significant responsibilities for me and my team that are outlined in here, but this is a plan for all of us, every single person at NSFT, and we have gone to the extent of spelling out accountabilities for each of the 6 domains that are outlined in the plan. And secondly, as we remarked earlier, the metrics and the measures and the targets that we've set ourselves for the 3-year programme that is outlined. There is very clear requests of the board in terms of a decision. Today we have some decisions for you in this particular paper, and that's all I wanted to say. Harpreet, did you want to say anything, or should we open up for questions? Thank you, Chair.
Brilliant, thank you. Questions? Helen?
Just a question about, I think it's a really good paper. The term inclusion advocate is used at several points. I just wanted to understand a little bit more about that role. Is it the role that I would know as cultural ambassadors in other organisations?
Yep, that's absolutely correct, Helen. Yeah, it's like cultural ambassadors, who champions. We've chosen to have inclusion advocates. They've been established for some time, but we will be revamping that.
And do they get then involved specifically in disciplinary processes and things, or is it a sort of broader role than?
Yeah, so they're essentially work as a champion. So they signpost, they support. The plan does set out how we will use them slightly differently in the future, so part of recruitment processes, formal disciplinaries, etc. as well. So we will be broadening out the role and putting all the training, support and development around those advocates too.
Super. Paul?
Thanks. Yeah, great paper, and I love the strategy that's been developed as a result of that. I think I've got 3 sort of questions really. The first one is around, this is a big, ambitious programme, and often it's quite challenging to see the dial move, and it takes a while. And a lot of the KPIs that we've got in here are probably measured annually. And I just wondered if we ought to consider whether or not there are KPIs that we could measure more regularly than that, just to see whether or not we're heading in the right direction, because to wait a year and then get the same results as we got last year, I guess, which is what tends to happen in this case, could be a bit of a challenge. So that was my first thought. My second was that I think you've laid out responsibilities and accountabilities, which is great, but often I think other things that are happening in the organisation can knock this sort of programme offline. So if there are service changes, or we've got a corporate service review, etc., undergoing, or anything like that can actually have an impact on the change that's been made around race equity. And I wonder how we actually make sure that that consideration of the impact in terms of race equity is actually built into every set of strategies or policies or activities that we're undertaking. Now, I know we talk about equality impact assessments, but I haven't yet seen an organisation that does them particularly well, and often they don't do them at all. So there are some real issues there, I guess. And then my final question really is that this, have we got the level of investment right for this particular programme, which is a pretty significant shift, and it's going to take a lot of energy and effort to make this work. So that's my final question. What's the investment look like, basically? Fair enough.
Great, really, really helpful, Paul. Thank you very much for bringing all of your expertise to the table. Who would like to respond to those?
Would you like to go first on measures and frequency?
Yeah, absolutely, Paul. So appreciate a lot of the current measures are very annual, but we do have existing measures in place as well through the Pulse survey, and we have the ability to have local questions in the Pulse survey. So my suggestion would be that we really put our arms around this piece of work through things like the Pulse survey, but also the qualitative feedback is just as important. So working with our staff networks and the staff network chairs, because if this doesn't feel any different to them, if they don't feel the impact, then I don't believe that we've been successful. So really keeping that dialogue open. And part of the plan also looks at how we capture those lived experiences, and we showed some examples of that at the race conference recently, where staff felt safe enough to speak openly about their experiences, and we'd like to do more of that as well, and that's built into the plan. In terms of responsibility and accountability, is absolutely, I think equality impact assessments, I agree with you. I think they're very difficult to do well. I do feel that we need to do some more work in the organisation to really train people up, and part of the plan is around helping people to understand what we're talking about when we talk about racism experienced by staff. And really that education, that commitment builds that understanding to do a much more fulfilling equality impact assessment. And I am pleased to say, I've been part of the corporate redesign work. I've just reviewed their quality impact assessment. It was really nice to see the growth that's already happening, but more to do.
Thank you. And finally, in relation to resourcing, there is separate work that sits alongside this that we've been looking at through execs in relation to resourcing. It's a consideration as part of our corporate redesign in terms of having the right people and skills to support delivery, but it's something that we must keep under review, absolutely, as the work progresses, and continue to not just that, but also engage with our staff networks around holding up the mirror in terms of are we delivering as we go down this path.
Great. I'm conscious of time. Caroline.
I didn't turn that off. Thank you. And Harpreet, Jeremy, thank you very much. It's absolutely brilliant to have got it to this place. And the profile I think this has got is fantastic. Just coming back to Paul, your, I think, really important question, and I think it's one that we do need to take away and think about, because we talked earlier about how we were going to build inclusion, and particularly race inclusion, into the IQPR. And if we keep the metrics annually, that doesn't enable a conversation, an accountable conversation with the localities and corporate services. Now, they won't all be able to be, but there'll be some metrics that we can probably, even things like engaging in reciprocal mentoring. There'll be some things like inclusion of interview panels that we will be able to build in and really force that conversation regularly across the organisation. So that's I would encourage us to just give that a little bit more thought. And just in terms of next steps, and particularly for the board, I'm delighted that we're in the final stages now of commissioning a BAME leadership programme that will also support allies, which is brilliant. And Yvonne's going to lead that alongside Harpreet. So we're really thinking about sustainability. But also for the board, we're all going to be encouraged to engage in reciprocal mentoring, aren't we, Harpreet? And we'll expect to see that pretty soon.
Yeah, absolutely. In fact, I'm bringing a paper next week.
Thank you so much.
Thank you. Any other questions? I'm conscious I slightly closed it down. We're not going to take long on the consent, but yes, Kath.
It's just a very quick point rather than a question, sorry. I think we've also got to make sure we recognise that this work is so important for our workforce to have the strongest, most capable people who feel supported to work in our organisation. But a sense of a lack of inclusion, particularly focused on race, translates into clinical practice. And we know 80% of black men enter into our services via the criminal justice route. You know, there's so many things that we just need to remember, not to take away from the importance of our staff, but to enhance it, because it affects every single thing that we do, whether it relates to our staff or the people that we serve. But thank you.
Thank you, Kath, for that. Well, I'm going to say something now. This report absolutely made my heart sing, not sink. I think this is an exemplar report. It sets out the what, the so what, and the what next, and it gives us a series of recommendations. It tells us what our problem is. It gives us a way forward with real clarity, and this, obviously the strategy is exemplary too. But in terms of this report, picking it up and reading it and getting to the end and thinking, yay, hallelujah, and then I even ringed in bright pink the fact that we've actually been asked to do something as a board, and I think it's really important. So Harpreet, Jeremy, team, I really want to commend you for bringing this in this form to the board, and I'm hoping that we see this being used as a model for future reports to the board. We're being asked to do a number of things. I'm not going to read them all out. They're all set out at 10, which is on page 469 of my paper pack anyway. Can I just check that the board is content to approve all of those requests, or I would say recommendations to the board? Yeah, brilliant. Thank you very much indeed. Thank you, Harpreet, and please take our thanks to all of your team for the work as well. Lovely. The next items are consent items. The annual report and the quality account have been considered in various other fora anyway. We're being asked to note the report and the quality account. Unless anyone's got any burning desire to talk about this again, could we approve them? Thank you. We've then got the report on research and development, which, as I mentioned earlier, I think is a superb report, and to have only 1 minute, if that, to consider it, I think is not doing it justice. So I just wonder how we can have a conversation more broadly about the extraordinary work of our research and development department moving forwards. You may not have an answer now, Caroline,
but we can build it into the cycle of board development, can't we?
Could we?
And we can think about how we want to really understand its impact and maximise that going forward.
Yeah. I mean, you pulled it out, didn't you, Roger, in your comments earlier, and highlighted the incredible work that's going on. And there's all sorts of research that could well help us very rapidly improve our services, and I think we need to give that justice. So could we note the report and agree to come back for further consideration as to that work of that team? And thanks back to John, obviously, who leads that department. Did you want to come in, Roger? Would you like to come in?
I just really wanted to make the point that we've discussed it thoroughly at Quality Committee, and there was one comment made that I think is pertinent. The research and development team is small but perfectly formed, and so our goal should be to make it big and perfectly formed.
And to have more light shone on it in terms
Yeah.
of celebration of the work that it does as well, because when you read through the report, there's so many, I didn't really understand it all, but prizes and commendations and all sorts of things that our staff are receiving, which is just wonderful to read. We do seem to be extremely leading edge in much of this, so we will note the report with congratulations, if that's okay. The customer service annual report again is a great report, so thank you, Kath, and your team for pulling that together. I think that there are a number of questions. I know that these are consent items, but I think there are a number of questions that I think we should be looking at perhaps in a little bit more depth. I know, again, that's gone through Quality Committee, but I wonder again whether or not we could pull out some time, maybe not in board, in public, to discuss some of those issues that come out of that report. But in the interest of time, I'm going to ask board to note the customer service annual report. Thank you. We've now got time for questions from the public. Addy?
There's one question.
Okay, and that's been answered, hasn't it? It's quite a technical
Yes.
question, wasn't it?
Yes, it has.
All right, okay. Do we need to, do we, I don't think we need to read it out in the answer now, do we? We can just publish that on our
Yeah.
website, is that correct? Okay, so we just received the one, but I see that Eric's got his hand up and would like to ask a question. And James.
Thank you. This question is not so much wearing my hat as a governor, but as a representative of Public Suffolk and also as a lived experience person. For the last 4 hours, my head has been doing some natural language processing and picking out a couple of words, which I've noticed have slightly changed balance in this meeting versus others. And that is a shift, a slight shift from involvement to engagement in respect of voices of lived experience and service users and carers. And that is to be commended, and I'm grateful about that. Involvement and engagement are not synonymous. And involvement is rather more about passive, maybe a little bit of listening, and engagement is more active and more committed. And I noted in the risk element of Kath's report from the Service User and Carer Council, speaking about if we cannot listen to and engage with partners, services, users, carers, etc., ... consequences. And also in regard to the crisis improvement programme, Kath also asked, can the voice of the lived experience and voice of carers be stronger in regard to active engagement and co-production? I personally have been involved in active engagement and co-production in the Op Courage, the Veterans Mental Health and Wellbeing Service, and specifically before Op Courage was combined, it was an integrated service. Previously, there were 3 other services, and one of those was the high intensity service. And now, again, in regard to the crisis improvement programme, there was speak about reaching out and learning and sharing from other trusts, maybe also from other services. And I think there might be a useful sort of pick and mix that can be taken out of the veterans, particularly the high intensity or the crisis element of that service. It might help to form or shape some of that which the trust is looking at. Not to copy at all, because it's slightly different, but actually there may be some opportunities there.
Thanks, Eric. A great, super observation. Thank you. You're absolutely right. And I saw Jeremy nodding to the suggestion that we draw on the learning from the veterans approach as well. So Stuart, I'll leave you to, if I may, to make contact with Eric after the meeting and arrange for that to be taken forwards. I'm going to ask James to ask his question.
Yes, thank you very much. The theme of my question is working with other outside bodies and other organisations, which I think is getting more and more crucial. Obviously, with the new 10-year plan that has already been discussed today, I think there are huge opportunities in that plan, but it will only work if we work with other organisations. So I think some of you have heard me kind of ask this or mention this before about our locality and the geographical areas of those, and how we, or you, sorry, the Trust, can actually suggest to the ICBs that they take those same areas, because it is absolutely crucial that those areas are coterminous, otherwise there's going to be difficulty. Also about other organisations, the learning to from deaths, quality data. I mean, a fantastic report. The amount of work that's been done on that is remarkable. But I would like to ask, how is that being shared with other trusts and other parts of the health system? Because I'm sure they have they have a need to know exactly the outcomes of that data as well, because it will influence some of those. And just the last point is on the 111 service, and we heard from the service user today, and may I congratulate the board in inviting service user of a situation that is not working as well as it could do, whereas we normally hear the ones that do work well. I say that with a bit of a smile, but I think that's very commendable. But the 111 service, I believe, should be as well as and not instead of. And there's only one time that I've picked it up, I might have missed a couple of other times, when Stuart mentioned the third sector. You know, Samaritans and others are out there, are recognised organisations, which I think are now being not so recognised, and is working with those organisations. So I just ensure that I'll ask that the Trust can look at that. And then I come to my actual question, because I know... well,
Hold on, James,
regarding
you had
data...
four already.
Thank you, Chair, but you'll allow me that, I'm sure. On page 117, there is the, in the IQ PR report, the eating disorders. And I noticed on there that it's on the West Suffolk there, that's on page 117, West Suffolk was 63.6 were seen within the 4 weeks. In East Suffolk, 0, and I think in Central Suffolk was also 0. Could I just have a little bit of more understanding of that, because it sounds rather odd to me. Thank you.
Great, thanks very much. Gary's popped up on the screen as well.
I've just... Sorry to interrupt, Zoe. Should we start from the reverse? Do you want to just deal with the issue around eating disorders, Andy?
Yeah, I'll try to, and hopefully I'll be brief. but yeah, the slide can be a bit confusing, but effectively all of our services under eating disorders are hosted under the West Suffolk locality. So ordinarily, all of our service users accessing eating disorders will be seen by the eating disorder service hosted in West. In this period, there's a slight anomaly in that teams outside of eating disorders in Norwich or in Central Norfolk and in East Suffolk saw somebody who was waiting for an eating disorder intervention, and that intervention stopped the clock. Therefore, it shows on here as East Suffolk and Central Norfolk not meeting any of the standards. So the Trust position in terms of this month for eating disorder performance was 57%. It's just a couple of people have seen outside of that, and that is an anomaly, and there is more deeper diving to do, as Caroline mentioned earlier today, in the Performance Finance Committee around eating disorder performance.
Very well spotted on that, James, and also for being here for the whole of the meeting as well. But Caroline's going to come back to you on your first two questions or observations.
Yeah, so I think the first was how aligned are ICB's footprints with our footprints? So in Suffolk, I think you probably know already, James, they're really, the alliance work is completely aligned, so we matched our footprints. They're well-defined places in Suffolk, East and West Suffolk. The bigger issue has been Norfolk, which has had a mix-up and lack of clarity, with some work done on a 5-place footprint. But since Ed has come across to Norfolk, he's articulated a clear wish to align Norfolk with the 3 localities that we've set up. So that is making progress. Now, of course, there's a lot of work to do with local authorities, but it gives an indication for the NHS that that's what the ICB would like to see, and then more work to do with local authorities, I'd say. And then on learning from deaths, just as part of that place work, massive amount of work that we need to do with voluntary sector, and then we need to be working out how do we work at a neighbourhood level within those places, localities, which is the work that we're starting to map at the moment. And then, really good point in terms of learning from deaths. I think we need to think collectively with Rebecca's support, how do we, it'd be good to get it written up a bit really and get it out there and published probably, get it into HSJ, get it into professional forums. So it's a really good point, because we have started, the people have started to contact us and we are starting to share, but we could do something more publicly, I think. Thank you very much.
Yeah, you're here. Thank you very much indeed, James. Great. Let's just move on to the next part, final part of the agenda. Have we lived our values during this meeting? Acted as a team? Oh, hello.
Oh, Sheila.
Sorry, Sheila. Come on in. Sorry, I couldn't see you over there.
Can you hear me?
Yes.
Yes. Right. Just a couple of comments about the wonderful way unexpected deaths are actually being categorised. I do agree with that. I've looked at the figures. The things that I picked out were unexpected unnatural deaths, 126. And if you add on to that 2% as a category of the 40 awaiting cause, you get a figure of 134. And we know really what those 140 people probably died of or with or because of. And I'm thinking, I'm remembering the figure that the Trust had in 2017. And so it was 134 if you look at my calculations for today, and 136 for 2017. So what I'm saying is we've got all the data, but the most important thing is the 136 people who've died and possibly could have been saved. And the second thing I want to say is something I just noticed in the paper about race, culture, and ethnicity of staff. And there's one line there which describes people as white leaders. And I don't think that all people of different ethnicities, cultures and race, we don't pick out people who aren't black, aren't white. So that really, I always notice that sort of thing, and I think we could be a bit more sensitive about it. Although the report obviously is good and picks out all the things that are going wrong, but that is a comment from me, because I don't.
Thank you, Sheila, and thank you too. And sorry I missed you over in that corner, but you've been here all day as a member of our Council of Governors as well. So I'd just like to say an enormous thank you to you for that. In terms of the detailed question you've asked on learning from deaths, I'm going to ask Gary and Anthony to come back to you in detail on that. I think there's perhaps some difference of opinion. I'm not going to do it now, Gary, you're going to do it offline. There's some difference of opinion of whether you can assume into some of the information that's unknown at the moment. So I think Gary and Anthony will talk to you about that. In terms of the point you've made on the race equity report, I'm going to ask Jeremy to have a quick word with you about that, just so we make sure we pick up the point in full and take it on board. So thank you very much indeed for that, Sheila. Great. Okay, let's move on to the last item on the agenda. Have we lived our values during the meeting, acted as a team, held each other to account, ensured we're learning and improving, and have we been kind? Well, I think Kath may say we've held one another to account, or she may feel that she's been held to account. And obviously I would hope that it was done in the spirit of this is what a unitary board is here to do, high support, high challenge, as we know from the board development that we've done. This is our opportunity to feed any reflections in while we're on the record. Caroline.
I think overall we have. My one reflection picks up from MC's earlier comment really, which is could we look at the agenda in terms of some of the areas we've made decisions and we asked for decisions, but we put it down as assurance. So I do think there's a little bit tighter around where we need to make decisions. Thank you.
Anyone else want to make any reflections? Jason?
Just about our kindness, and it's the kindness in terms of kindness to ourselves with the number of papers that we've got and the size of the papers, and can we try and reduce the size to be a bit kinder to ourselves to enable us to read.
It's not just being kind to ourselves, is it? It's actually doing justice to the big ticket items that we really need to have important discussions on as well. But it's really well framed in the sense of being kind to ourselves. Yes, I will always remember reading 661 pages, but luckily sat in the garden with my mum yesterday, who's with me at the moment, which was very nice. But yes, a few less pages would have been better. Anyone else got any thoughts or reflections? No? Okay, thanks very much indeed, everyone. So our next meeting is on the 2nd of October, very sadly without Tricia, which is an unthinkable thought, I know, for all of us. And it's in County Hall in Norwich. And we also approve the exclusion of press and public for the confidential part of the meeting, now to be held at Kesgrave Community Centre. We're happy to exclude press and public. Thanks very much indeed, everyone. That's the end of Public Board in Public. Well done.